Good evening, friends, senior professors, invited faculty, students who have joined on YouTube and on Zoom Tube. Thank you for joining us today, this evening. We have two important cases. One is a case of thyroid swelling, kindly contributed by Professor Farhanul Huda and Professor Som Prakash Basu sir from All India Institute of Medical Sciences, Rishikesh. We have the other case contributed by Professor Rajavelu from Government Vellore Medical College to be presented by Dr. Surya Narayana. Thank you all the faculty for kindly contributing your time and permitting your postgraduate to present in this forum. And Dr. Rajavelu sir has informed that he'll be joining us shortly. He's just finishing a surgery. So we'll have the first case to be presented by Dr. Jaini. So Guru Shantapa sir, I think we have Srinivasan sir to start the discussion. Good evening, sir. Karnagaran sir is also with us. I would like to briefly tell the presentation format will be a teaching format. So candidate will allow to be present till the history part, stop there. Then she can be questioned. Then she is allowed to present through the entire clinical finding. Then she can be allowed to question initially on how she has arrived at the diagnosis. And later she can be taken to the investigations and management part of it. So this will be the plan. We have 1 hour time for each case. So examiners feel free to correct the candidate and give the right answer if she or he gets stuck or something. So I wish all of you a lot of good learning and academic deliberations. And Dr. Jaini, best wishes to you. And with the permission of the faculty, please introduce yourself and start your presentation. Kindly share your PowerPoint.
Yes,
faculty, sir. Kindly take over. And on behalf of the postgraduate clinics and the faculty and the students, we wish a lot of happiness in the auspicious day of Holi and wish a lot of happiness and joy in every one of you and your neighbors. Thank you very much. Over to you, Dr. Jaini.
Thank you, sir. Good evening, respected faculty. Very happy Holi to everyone. I'm Jane John, PG resident from Department of Surgery in AIIMS Rishikesh. My HOD is Professor Somprakash Basu, and this was done under the guidance of Dr. Farhanul Huda sir. To start with the case, for the patient details, Mrs. X, a 50-year-old lady, married, Hindu, homemaker, resident of Haridwar, Uttarakhand, presented to the OPD on 7th of March of this year. She presented with a chief complaint of swelling in the anterior aspect of the neck for the past 23 years. For the history of presenting illness, she complained of a swelling in the anterior neck for the past 23 years, which is insidious in onset, started while being pregnant, and it slowly progressed to its current state. It was painless and it was associated with heaviness, but there was no change in size of the swelling post-pregnancy, and there was no sudden increase or decrease in size or color of the swelling. She also complained of undocumented weight gain. There was no history suggestive of hyperthyroidism or hypothyroidism, no history of fever, pain, or sudden change in size of the swelling. No history of change in voice, difficulty in breathing, or difficulty in swallowing. No history of any other neck swelling. No history of back pain, or bone swelling, hemoptysis, or any other swelling. 15 years prior, she sought consult for the same, and she was planned for surgery. But at that time, she was not willing to undergo the surgery, so she refused that. And she discontinued any other, she did not go for any consult. Then 6 years prior, she went to an Ayurvedic doctor, and she was prescribed unknown medications, which she took for about 3 to 4 months. She then sought consult in AIIMS Rishikesh. Between that time period, she did not take any other medications. For the past medical history, she is not a known case of diabetes mellitus, hypertension, coronary artery disease, tuberculosis, or any other illness. She has no history of radiation exposure and no past history of any surgery. For the family history, For the family history, her mother had history of a thyroid swelling when she was in her 40s, which was operated, but there are no documentation of the same, and she does not know about the diagnosis. Her mother was fine in the post-operative period. Her sister has a history of hypothyroidism and is on medications currently, which is currently well. Her father also has a history of diabetes mellitus type 2. She has no other family history of any malignancy or any other diseases. For the personal history, she's a vegetarian. Her appetite is good. She sleeps 8 hours a day adequately. She has no known allergies. She has no history of any addictions, and she has normal bowel and bladder habits. For the menstrual history, she has one girl, which is delivered via normal delivery, normal vaginal delivery, which had no complications, and her child is alive and well. Her menarche was at 12 years of age, and her menstruation was regular, occurring every month, lasting for about 3 to 4 days per month, per cycle, and she used around 1 to 2 pads per day. She's currently postmenopausal for the past 1 year. For the treatment history, she visited multiple local practitioners for these complaints, as I had previously mentioned. She was planned for surgical intervention, but she did not. She was unwilling to do so at that time. She also took unknown Ayurvedic medications for 3 to 4 months. She had no relief of the symptoms, so she came to AIMS Rishikesh. For the summary of the history, a 50-year-old lady with complaints of anterior neck swelling for the past 23 years with undocumented weight gain and no toxic symptoms.
Gurushantapa sir, you're muted, sir.
Yes, sir. Yes, sir. Yes, sir. Yeah, I'm muted now. Doctor, you have done with the history?
Yes, sir.
Yeah. So what do you think at history level probably this lady has?
So at this point, based on the history, I'm suspecting a multinodular goiter, a goiter, sir, simple goiter. Also, because of the long-standing duration, the possibility of a malignancy should also be taken into account.
Mm-hmm.
Yeah.
Any better way of putting this? If the question is, what is your thinking at this point of time?
So I'm thinking of a multinodular goiter, which is clinically euthyroid. Secondly, I'm also considering thyroid malignancy in view of long-standing goiter.
Okay. I don't know if you can put straight away as multinodular goiter at history level, probably will not be accepted.
Yes, sir.
So in a old lady, that is a 50 years lady, probably you are thinking in terms of a thyroid swelling at this level.
Yes, sir.
Because her chief complaint is swelling.
Yes.
And you have been asked to know your thinking at history level. So you have to put in like swelling only.
Yes, sir.
Okay, goiter, even though it is a layman term, sometimes it is accepted. It is a medical man, that is any thyroid swelling. So you are thinking in terms of a thyroid swelling.
Yes, sir.
And probably patient doesn't have any toxic symptoms, so it is in euthyroid status.
Yes, sir.
Okay, and you substantiated that because she has a history of 23 years duration. So you said you are thinking in terms of a possibility of a malignancy.
Yes, sir. It cannot be ruled out at this point.
Does it go in favor of malignancy if history is for 23 years?
So apart from the long-standing duration, there's no other symptoms that is suggestive of malignancy.
Then why did you think in terms of malignancy at this point of time, at history level? You said the possibility of malignancy.
So only in view of the long-standing goiter. So there are no other symptoms. There's no voice change. There's no other symptoms.
That's what I'm asking. Long-standing duration, will it go in favor of malignancy pertaining to thyroid swellings?
So there
you have probably you have misunderstood the duration of a swelling and thyroid cancers. You have misunderstood. Okay, this lady doesn't have any symptomatology of local disease, which is suggesting that probably it is a malignant swelling. Has she got any symptoms?
No, sir.
She doesn't have. Okay, so longer duration, there are chances that the impression of a thyroid swelling pertaining to duration is longer duration. There are chances it can have a malignancy, but that doesn't favor malignancy unless there are symptoms.
Yes, sir.
local symptoms in the form of stridor.
Yes,
The
sir.
symptoms of change of voice indicating there is something concerned with the recurrent laryngeal nerve, or she has got a history of dysphagia or breathing difficulty, or she has come out with a history of some other swelling in the neck,
Yes, sir.
which you may diagnose later that it is a lymph node swelling.
Yes.
So if we have such symptomatology along with a longer duration, you can say, even though it is a longer duration, because she has symptoms so and so, the malignancy cannot be ruled out.
Yes, sir.
But if she doesn't have other symptoms which I have suggested, if it is a longer duration, you cannot put the possibility of cancer here.
Okay, sir.
Later on your examination, you may find some findings in favor of malignancy. That is a different issue.
Yes.
So at history level, for this lady of age 50 years with no toxic symptoms, so you are thinking in terms of a thyroid swelling. Why thyroid swelling you are thinking in terms of?
Because in the anterior aspect of the neck.
Exactly, exactly. What is the commonest neck swelling in any patient?
Goiter only, sir.
Goiter. Commonest neck swelling. Neck
So it
swelling.
can be lymphadenopathy. So if it is in the neck.
Yeah, lymph node swelling is the commonest swelling.
Yes.
Okay. So at this point of time, probably you are thinking in terms of a thyroid swelling. If it is asked, what is likely pathological condition, you are thinking in terms of, don't put malignancy as the first. Still, it is a benign disease because she doesn't have any local symptomatology.
Yes, sir.
Okay.
Yes.
And you have mentioned that she has got a weight gain. So anything you want to add to history level thinking?
So her appetite was normal only, sir. That's the weight gain was also part of, it can be separate from the pathology itself.
No. If I say you contribute this weight gain to thyroid disease, so what is the thyroid disease you are thinking in terms of?
The hypothyroidism, sir.
Exactly. So likely that, so can hypothyroidism and a goiter will go hand in hand?
Yes, sir, it can still go ahead.
Huh?
Yes, sir, it can. We can still have.
Is it normal or abnormal having hypothyroidism and a goiter?
So that's abnormal, sir.
Why abnormal?
So there is a possibility, sir.
There is a possibility.
Yes, sir.
Why they will have goiter in hypothyroidism?
So long-standing, if there is a long-standing goiter, the goiter itself can replace the normal thyroid tissue. So the follicles can get damaged and then they won't be enough to mount a response.
No. You are thinking explaining another way around. If a patient has got hypothyroidism, can they have a goiter?
Yes, sir. Because of the constant TSH stimulation. Because the
increased TSH levels.
Yes, that can cause the goiter.
Increased TSH levels. TSH levels.
Yes.
That will stimulate the thyroid gland and results in a goiter.
Yes.
So it is a classical at history level that probably she is a hypothyroid case primarily, resulting in goiter formation, and she has presented with a neck swelling.
Yes.
Sir, other faculty, sir?
Yes, sir. Good evening. Good evening, Guru Shantapa, sir. Good evening, Jailal, sir.
Yeah, good evening.
Namaskar.
Yeah, sir.
Yes,
Srinivasan, sir. Good evening. Good evening, sir.
In general, sir, the professor was asking long-standing swelling. So, in general, you tell me what are the points to say a long-standing swelling is turning into malignancy. Suppose the long-standing swelling is turning into malignancy. What are the points you say? In general, anywhere.
So if there is any change in the size of the swelling, if there is any rapid increase or decrease, rapid increase in the size, any change in voice, if there's
I'm telling anyway, in general. Suppose you have a swelling in the arm, you have a swelling in the thigh. Any swelling, one is change in size, yes.
If there is
painless becoming painful.
Yes, sir.
Change in consistency.
Yes,
mobility becoming restricted or fixed.
Yes, sir.
Skin changes.
Yes, sir.
Lymph nodes. These are the 6 points. Anywhere as long-standing swelling is turning into malignancy. Now, pertaining to certain areas, here in thyroid, now is that you will have compressive symptoms.
Yes.
Okay, so you should say sudden change in voice.
Voice.
Okay, it's a change in voice, increasing in size, compressing on the trachea. These are the things. Was there any changes associated? Long-standing, so long it has been there.
Yes, sir.
Was there anything?
So she did not have any change in voice. She only had some heaviness. She didn't have any dysphagia. She didn't have any change in voice. No change in size of the swelling also. Not associated with any pain also, sir.
That heaviness is due to the increase in the size, that's all.
Yes.
But
Yes,
there has
sir.
not been any rapid progress.
No, sir.
So you can rule out malignancy at this stage because you can say it's a goiter in a
Yes.
euthyroid state. That is enough. So
Yes.
now further coming to your clinical examination, after that you can come to a conclusion. And as
Yes.
Sir said, don't say multinodal goiter on history alone.
Yes, sir.
We come to the inspection.
Inspection.
Yes, sir. Jailal sir, please take over.
But why do you want to say it is a summary? I cannot see the original. With the
Yes.
anterior neck swelling, and suddenly you are asking for a toxicity.
So voice low work, sir.
Sir?
Jailal
Sir,
sir, voice.
Yeah, why do you want to suddenly mention that swelling as an anterior neck swelling and suddenly adding that there is no toxic symptoms?
So I want, because it is an anterior neck swelling, I was considering that it will be a thyroid, and I wanted to see if it was a benign or a malignant thyroid. Benign thyroid function.
Normally in a postgraduate, when you are presenting at so much of history, when you are coming, if you are not able to come to a conclusion anatomically, it is a thyroid swelling.
Yes.
So that is
Well,
contradictory. You are saying anterior neck swelling, so there are so many reasons you are having. Then you
Yes.
should say that there is no fever
Right.
because the tuberculosis can be there, secondaries could be there.
Yes.
So now you must be very particular whether the swelling is in the thyroid region.
Yes. Sir. So it's a thyroid swelling.
Instead of making it as an anterior neck swelling, and it is bigger, more specifically, if you can bring, it will be
Yes.
much better. What is
Yes.
thyroid region?
So T3, T4, sir. T4.
Thyroid region.
So anterior neck, anterior aspect of the neck.
There is nothing
Between the
called anterior
sternocleido.
aspect of the neck, posterior aspect of the neck. They are only called triangles.
Yes, sir. In the,
What do you mean by thyroid region? What is the boundary of thyroid?
so it is between the thyroid cartilage and the it should be in between the sternocleidomastoid muscles laterally and between the thyroid cartilage and the sternal notch.
To the sternal notch and thyroid
Deep to the
What is upper limit? Is it up to the upper end of the thyroid cartilage?
yeah, it can go up to the thyroid cartilage, sir.
What do you mean by oblique line of thyroid cartilage?
So I'm not.
Where the muscles of thyroid are attached? What are the muscles arising from thyroid cartilage?
So there is the strap muscles are also there in vicinity of the thyroid, sir. Thyrohyoid.
Okay, where is that attached? Why
So
the
the,
thyroid cannot go beyond that level? Why the
because of the
thyroid
fascia, sir. Because of the pretracheal fascia.
It is not because of the fascia. It is
So
because of the muscles you are getting.
Yes.
So these muscles, whether the sternothyroid or thyrohyoid, they are at the oblique line.
Yes.
So that is the boundary. Without
Yeah.
crossing that, it cannot go upside. Okay. So normal thyroid region, it is upper limit. You must be specifically say. In anatomically, clinically, it is very difficult to see in the surface marking the oblique cartilage. But you can say it is justified if you say it is a upper end of the thyroid cartilage. But if the question is asked, why, what is the significance of oblique line, and you must be know that. So I will be preferring when we are coming to the conclusion summary, more specifically saying, not beating around the bush, say that I have a swelling in the thyroid region for 23 years and with no toxic symptoms, and you are not mentioning anything about malignant symptoms in this summary. That
Yes,
you are
so
not asked any questions on that.
So in the previous slides of this, sir, there's no feature suggestive of malignancy, sir.
No, in the summary you must bring that. You are very specifically saying no toxic symptoms.
Yes,
Then
sir.
you must also say there is no features that you are not able to get.
Okay, sir.
Okay, go ahead. You can go to the clinical examination.
Okay, sir. For the general physical examination, the patient was conscious, well oriented to time, place, and person. She was comfortable and cooperative with no notable anxiety or restlessness. She was well nourished with average build. Her BMI was 30.5 kg per meter square with an ECOG of 0. For the vital signs, the temperature was 98.7 degree Fahrenheit. Pulse rate was 89 beats per minute, regular, with good pulse volume. It was measured in the right radial artery. The respiratory rate was 18 beats per minute, and the BP was 107/62, measured in the right upper limb in the sitting position. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. For the hair was normal in appearance. There was no alopecia. no facial puffiness, no loss of lateral eyebrows. There were no eye signs. There was no tremors also in the tongue. The nails were also normal. There were no signs of thyroid acropathy. The skin of the hand was also normal. It was the skin of the hand was also normal.
No, in the general examination, you are going to look for the tremors in the tongue.
So that was after the general. So this is head to toe, sir. Sorry, the heading was.
You are putting that tongue, there is no tremor. Why do you want to go and look for a tremor in the tongue?
So if there's any signs of toxicity, sir.
Is it a tremor you get in the
The
tongue?
fasciculation.
What is tremor and what is fasciculation?
So they can be tremors because of increased adrenergic activity, sir. Fasciculation is mostly lower motor. So
what is the definition of when you say something is a tremor? What is the definition? And you say fasciculation, what you are going to look?
So fasciculation is fine.
What is the difference between fibrillation, fasciculation, and tremor? Fibrillation is a single muscle fiber. Fasciculation is a group of muscle fiber. It is not the entire muscle you are going to get it.
Yes.
And then tremor is a rhythmic, coordinated, symmetrical movement which is taking place. What type of tremor you get in thyroid? If at all you are expecting tremor, what type of tremor you get?
Fine tremor.
Huh?
So fine tremor.
What do you mean fine tremor? How do you measure the tremor? What are the criteria to say? The frequency and amplitude.
Yes, sir.
So fine tremor means what is the low frequency or high frequency? Or amplitude is high or low?
So it will be low amplitude, high frequency.
Is it a physiological tremor or not physiological tremor you are going to get in a thyroid?
So it is non-physiological.
It is physiological. No? Normally in the physiology you get because of anxiety, because of your, catecholamines, you are going to get a tremor. It is exaggerated physiological response. Nothing pathologically is taking place with the tremor. So how do you check for the tremor?
So so for the tongue, we ask the patient to put out the tongue, sir.
You want to put out the tongue for checking for a tremor?
So sometimes we can also ask the patient to open her mouth and we can visualize the tongue when it is resting.
Sometimes and then what you will do in the examination, you can't say sometimes I will do like that, sometimes I will do like that. It is what is the philosophy you are giving.
Yes. So I'll ask the patient to put out the tongue.
So that any fine tremor you need to have an outstretched hand. With the hand only you are going to see. Here you are only seeing the fasciculation. When you are going to see the fasciculation, you are not going to put the entire muscle into contraction. That is why you want to see fasciculation inside the mouth with the mouth open, not putting the tongue outside. But when you are going to measure for the fine tremor, you need to stretch your hands up and ask the patient to extend the position, and then you are going to check for the fine tremor. So be cautious. Don't use these words, tremors. You need to study. As a PG, you need to study what is coarse tremor, what is fine tremor, what are other type of tremors you will get in the surgical conditions. Okay.
Yes, sir. Yes.
Good evening. May I just ask a question, Jane?
Yes.
You said anxiety. How do you distinguish anxiety from thyrotoxicosis? Suppose a patient is having anxiety. How will you distinguish it from thyrotoxicosis?
So the resting, we can see the resting, sleeping pulse rate.
That's you can't get a sleeping pulse rate. It's very difficult. Something better. Anything else?
You will not be able to. The examination will not extend to the night.
Yes, sir.
So it's something more clinically oriented. Okay.
So if any features that are suggestive of toxicity, like eye signs that will not be present in.
No. In this patient, suppose they don't. Eye signs are not very common, unless they're for a prolonged period.
Yes.
They may or may not be there. Okay. When you feel the palm, in anxiety, it will be cold and clammy skin.
Yes.
Right. While in thyrotoxic, it will be warm and clammy.
Warm.
This is the only difference. Otherwise, they all have tachycardia, sleeplessness, tremors, everything is there.
Yes.
Okay. Right.
This patient is 50 years old, no? You are expecting, suppose you're getting the toxicity, you are getting a primary or secondary?
So secondary tox.
What type of eye signs you get in a secondary thyrotoxicosis?
So usually we don't get eye signs in secondaries.
Really?
More of cardiac.
What is the eye sign you get in a secondary thyrotoxicosis? See, if you see lid lag, what is the reason for lid lag and lid retraction?
So that is because of because of the increased activity of the levator palpebrals superiors. So it goes into retraction because of excessive sympathetic drives.
Do you have excessive sympathetic activity by the secondary thyrotoxicosis also? Indeed, you are having both lid lag and lid retraction can be there. See, only in a Graves there is a specific reason, not due to the increased sympathetic activity, because of antibodies.
Because of the antibodies.
Then you are getting other eye signs. So
Yes.
all other eye signs are specific to the Graves disease, but lid lag and lid retraction is only due to the hyperthyroidism. Whenever you get an increased sympathetic activity, whether it is a primary or a secondary, you can still get lid lag and lid retraction in the patient.
Yes.
Go ahead, ma.
Okay. For the moving on to the inspection findings, a swelling of size 10 to 5 centimeter situated in the anterior aspect of the neck, which is extending from the upper border of the thyroid cartilage to the sternal notch. The lower border cannot be clearly visualized. Bilaterally, it was extending under the anterior border of the sternocleidomastoid. The surface appears smooth with well-defined margins except for the inferior margin, which could not be visualized on inspection. On inspection, the swelling also moves up with deglutition, but not with protrusion of the tongue. The overlying skin was normal. There were no scars or sinuses. There were no distended neck veins, and no other visible swellings were noted, and the Pemberton sign is negative. For the palpation, a well-defined swelling of size 11 to 5 centimeters was situated in the anterior aspect of the neck, which was involving both lobes of the thyroid, and is extending from the upper border of the thyroid cartilage to the sternal notch, bilaterally between the anterior border of the right and left sternocleidomastoid. The swelling moves up with deglutition, and on deglutition, the lower border of the swelling could be palpated, but only on deglutition. The swelling had a bossulated surface with variable consistency. The swelling was non-tender with no local rise of temperature, and the bilateral carotid pulsation was palpable, and the Berry sign was negative. The trachea could not be palpated. Sorry, sir? The trachea could not be palpated, and there was no cervical lymphadenopathy. On percussion, there was a resonant note over the sternum, and on auscultation, there was no bruit heard over the swelling, and the air entry was heard in the midline. So can I move on to the systemic examination?
Yeah, you finish your exam.
Yeah, please finish it off. Finish it off.
Okay.
Then we'll come back to the discussion again.
For the systemic examination, the respiratory system, there's bilateral air entry. There were no added sounds. The cardiovascular system, S1 and S2 was heard. There were no audible murmurs. The per abdomen and back findings were within normal limits. For the musculoskeletal examination, there were no lesions, no spinobony tenderness, no resting tremor was noted, no pretibial myxedema was noted. The CNS examination was within normal limits. For the summary of the case, a 50-year-old lady with complaints of anterior neck swelling for the past 23 years, with undocumented weight gain and no toxic symptoms, and no signs of malignancy. On examination, there was a thyroid swelling of size 11 to 5 centimeter, the bossulated surface, well-defined margins, variable in consistency, non-tender with bilateral carotid pulsation palpable. So can
Doctor, can you have some clinical photographs? You have any clinical photographs for this patient?
So actually, we don't have. It was an OPD patient. So the patient was supposed to come back yesterday, but because of Holi, she didn't come.
Okay, yeah. I insist, even if it is a OPD patient, you will be having your mobile in the pocket, no?
Yes, that was.
Yeah. Instead of having selfies, I think it is worth having clinical photographs from patients. Okay.
So sorry.
It's all right. Because that would have given us a lot of information. We would have understood your description and the clinical photographs are correlating. Okay.
Yes, sir, sorry.
I could see there are many things in the. It's all right. It's all right. In the slides, you said the size of the swelling is 15 by 10 centimeter. Is it right? 10 by 5 centimeters.
So yes, sir. 11 into 5 centimeters, sir.
Okay, fine. Do you expect such a big swelling to move with protrusion of the tongue?
So no, sir, only on inspection I wanted to confirm, sir, and
No,
palpation.
is it required? Is it required for
required.
this patient?
Not required, sir.
Then not to mention. Not
Yes,
to
sir.
mention.
Yes, sir.
If it is not required, you are mentioning, you are conveying that you want to mention everything to every case without
Yes.
understanding the importance of that particular test.
Yes.
Okay.
Yes,
What
sir.
was the need of mentioning scars and sinuses in this patient?
So
Was it required?
So the scar, if there was any previous history of
That
previous
history would
surgery.
have been there and you would have mentioned the scar. If it is
Yes,
not
sir.
there, why you want to highlight?
Yes, sir. Not necessary.
And where do you expect sinuses in a case of anterior neck swelling? Do you expect sinuses?
No,
So
sir.
why you want to invite questions on that? Okay.
Yes.
So
Yes.
if it is not there, don't mention.
Yes, sir.
Is it really required to mention tenderness and raised temperature for this case? Is it required?
So in this case, based on history, it's not required, sir.
Not history, even in your examination.
Examination also not required, sir.
In this, after doing everything, you will present the case. It is not that you are asking the patient and presenting the case to us. You have done everything and you are presenting the case.
Yes.
So is it required to mention tenderness and raised temperature for an anterior neck swelling?
So in this case, not necessary, sir.
Not
just
required.
completion. Yes, sir.
It is not required. You please note down, you just don't listen here and leave it from the other end and again present the same thing to the next case. Okay, at this point, all of us highlight to every candidate whenever they present an anterior neck swelling, but repeatedly we hear these things.
Yes.
It means that whenever we say this, you people are not concentrating and try to implement for the next case. If that is a situation, probably the idea of what all of us are doing is not fulfilled.
Yes, sir.
You got the point, because you need to teach your undergraduates. No, once you go out and teach your undergraduates, you need to highlight that these are the points which are not required whenever we present a case of anterior, because otherwise you need to substantiate.
Yes, sir.
The next question would be mention some thyroid diseases where you will have tenderness, where you will have raised temperature. That is how you will be inviting the questions. Unnecessarily, everything will be diverted.
Yes.
You want such questions to be answered by you now?
No, sir.
You want to answer such questions, or you want to discuss this case?
So we want to discuss the case.
Exactly. Even we are not interested in discussing such questions. So
Yeah.
no tenderness, nothing. That should not be brought at all for this case.
Okay, sir. Okay.
Okay.
Okay, sir.
Yeah. And you said somewhere, you said bossylated surface. How do you say it is a bossylated surface in palpation?
So actually, so there was there are large nodular swellings that are combined together, and you can sometimes feel a ridge, a groove, sir. Groove.
So the combined nodules form bossylation.
Big.
Is it like that?
So big nodules, sir.
What is that? When do you say it is bossylated? When do you say it is nodular? When do you say it is smooth?
So
Or when do you say it is a granular? One more entity.
So in nodular, we can clearly delineate multiple nodules, and we can delineate some of the borders of the nodules also. But in a bossylated surface, we are not able to distinguish between the multiple nodules that are there. They merge and they form like a single big nodule.
Okay.
Sometimes they can form.
What we expect best would have been a clinical photograph which would have given us views that yes, is it bossylated, we should accept, or we should put it as a nodular. The size criteria is more than 3 centimeter, we take it as bossylations. Less than 3 with multiple entities, we take it as nodular. And granular, some examiners insist that you should mention, which probably clinically it will not be appreciated. Okay, lesser than that. But you should be careful when you present this, whether really you want to say bosylation or a nodular one.
Yes.
Okay.
Yes.
Where exactly did you palpate for carotid before you concluded that they are fed? Where did you palpate in this case, such a big swelling?
So in the anterior aspect of the sternocleidomastoid.
Means what?
In the
aspect of sternocleidomastoid means what?
At the level of C6.
How do you make out C6? No, you cannot palpate C6
Yes, sir,
from
the
anterior
cricoid.
side. You cannot palpate because thyroid is sitting here.
Yes, sir. The cricoid cartilage, sir.
Cricoid will be in the midline.
Yes, sir. So at that
And
level,
swelling is.
yes, at that level, the corresponding at that level palpated for the carotid. So also previously
in the midline.
No, sir. And the anterior aspect of the sternocleidomastoid, sir.
Okay, you should have nicely mentioned we teach for undergraduates, no? Line drawn perpendicular
Yes,
from the superior part of thyroid cartilage to anterior part of sternocleidomastoid, where exactly this line meets. You have to palpate one at a time with a thumb, because carotid is a vertical structure. You have to feel transversely, not C6. C6 is a surface marking.
yes,
Surface marking is different. Clinical examination is different.
yes, sir.
Okay. Why did you check for carotid in this patient?
So I wanted to see if the pulse was displaced laterally or if it was decreased. Because I was initially suspecting the malignancy also. So I wanted to see if the pulse was decreased or if it was displaced or absent.
Sir, Jailal sir.
Yeah, what you said very sign is negative. What do you mean by that?
So the pulse was palpable, sir.
No, why when you will not see the pulse?
So if there is involvement of the infiltration of the carotid sheath, sir.
Carotid sheath is a thin sheath. Carotid artery is a very much pulsating.
Yes, sir.
Then if you think that the carotid sheath infiltration will be able to stop the pulsation to be felt, if the flow is stopped, or you are not able to feel
The flow won't be, sir. We won't be able to palpate it, sir, because of the infiltration.
why there is a flow, it can be able to produce the pulse.
Sir?
The vein is also very flow.
Sir, I'm not, sir, can you please repeat?
Sir,
I'm not.
sir, Jailal sir, your audio is not clear. Your audio is not clear, sir.
I will go to the different place. I was in the house. Okay.
Yeah, now it is here. It is heard now. It is heard.
You mean to say, and is it due to the carotid infiltration, carotid sheath infiltration you are not getting, or anything else?
It can be displaced also because of the size of the swelling itself.
Displaced is not due to not positive for the berries, no?
No,
So
sir.
it is invariably the pulse is produced only by the muscles contraction. The carotid has a muscle contraction, that is a tunica media. It is a relaxation and the contraction. Only when the tumor is infiltrated into the muscle cells, when the tunica media or intima is infiltrated by the muscle, the pulse will not be able to generate it there. That is why you are not seeing. Still, you will be able to feel the flow will be there. And you also said you are looking for the bruit. What was your auscultation finding?
So if there was no bruit, sir.
Why do you go and look for bruit? What was your auscultation finding? What you heard in the auscultation?
So I didn't hear anything, sir.
Then there's something wrong with your ear or something wrong with your chest.
So only
when you are auscultating the thyroid region, definitely you will feel some upper limit. You will definitely hear something there.
So only on auscultation, I only auscultated when I auscultated the midline, I was able to hear some air entry. But apart from that, I checked in the superior pole, I was not able to hear.
Please remember, you are not going to auscultate the region for hearing the bruit. You are saying that when you are auscultating on that superior part, first you will be able to hear the cardiac sound, you will be able to hear. You will be able to hear the tracheal, the breath you should be here. You said you are not able to palpate the trachea.
So I was not able to.
You were not able to palpate the trachea. Means you need to auscultate for the trachea.
So I've auscultated in the midline, sir. So I'm not able to hear you, sir.
Something wrong.
Jailal sir, there is some disturbance from your side. Jailal sir, yeah, the voice, there is some disturbance from your side. No, what he wants to know, doctor. You're able to hear, John?
Yes, sir. Yes, sir.
Yeah, what sir wants to know, whenever you comment on trachea in a thyroid swelling,
yes,
rather than mentioning palpation, which will be very difficult because the thyroid is situating on that area, it is better you should mention non-auscultation.
Yes, sir. So,
is it a gush of air column heard on auscultation? Is it in the midline or is it shifted to one of the sides in auscultation? That is a better way of confirming. In fact, it will be asked sometimes in the examination, how do you confirm clinically the position of the trachea in a goiter? It is by auscultation, not by palpation.
Yes.
Yeah. Okay, you said there are no palpable lymphadenopathy in the neck.
Yes, sir.
Why did you examine for lymph nodes in this case?
So because of the long-standing duration, I wanted to see if there was any other lymph nodes, just to rule out, so as part of complete thyroid examination.
I don't know why you have fed up your brain with long-standing duration and thyroid cancer repeatedly, in spite
Yes,
of
sir.
we.
So that was
Even
the
Srinivasan. No. Listen,
yes, sir.
lady, listen.
Ji,
Even
sir.
Dr. Srinivasan mentioned that you don't bring that unless patient has got those symptoms of local invasion, which she doesn't have.
Yes, sir.
So every time, whenever we talk about the thyroid cancer, you are bringing the 23 years duration of. I don't know. You are fed up. Like you are fed your brain with that.
No, sir.
Take out that first.
Yes. Sir.
Okay. Any thyroid swelling in clinically euthyroid status, your examination is incomplete unless you examine for neck nodes.
Yep.
More so if the patient is male.
Yes.
You got the point. That is a dictum.
Yes.
So you need to examine, not duration. It is that you need to examine and look for lymphadenopathy. Yes. If I ask you to examine only one area of the lymph nodes, keeping that probably there is a malignancy inside, which is that group you will be examining and giving a comment that yes, it is palpable or not palpable. Only one group I'll ask you to examine.
Level 6. Level 6.
How will you palpate for level 6, lady?
So the level 2, 3.
You'll be able to palpate level 6. So
level 2, 3, 4 will palpate.
I gave only one group I'll allow you to examine, which is that group you will be examining and give a comment that yes, it is felt or not palpable or palpable.
So level 3, sir.
In other words, I'm asking you, which is that commonest area of the cervical group of lymph nodes, which are commonly involved in thyroid cancers. Clinically, which can be clinically examined.
So if only one, then level 3, sir.
Level 3 nodes. Level 3. Clinically, which can be examined. But if it is asked, what are the commonest nodes which are involved in thyroid cancer? Which are the nodes?
Level 6.
6, what you said, pretracheal and paratracheal. Clinically, we will not be able to palpate them.
Yes, sir.
You got the point?
Yes, sir.
Okay. Sir, shall we go with the diagnosis now? Jailal, sir?
Repeatedly use the word long-standing. In the long-standing thyroid, will you do a Cocktail's test?
Sorry, sir?
Will you do the test for the integrity of the thyroid cartilage, Cocktail's test?
So we are not supposed to do it, sir.
Who said?
So if we can do it, sir. If we do that, the patient might go into stridor, sir. So some people say not to do that test. It might be dangerous.
What's the purpose of doing that test?
So if we want to see if there is, if in long-standing goiter, if there is any tracheomalacia, the patient might go into stridor, sir.
What do you mean by tracheomalacia?
If there's any weakening of the tracheal rings, sir.
Paralysis.
Yes, a paralysis. If there is any weakness.
How do you say cartilage will get weakened? Muscles will get weakened, paralysis.
Yes, sir, the muscles.
Cartilage. What is the exact word? What is happening in the cartilage to get that you are getting weakening?
So tracheomalacia. So
shape of the trachea.
So it is tubular, sir, with C-shaped rings.
C-shaped ring. Entire thing is a tubular.
No, sir.
C cannot be a ring, no. C cannot be a ring.
Let us start.
C-shaped ring, it cannot be. They will not go hand in hand. You have to either select O and ring or C and half ring.
Why do you want the trachea to be always kept open?
For effective breathing and ventilation, so passage of air.
You are breathing only 16 times per minute. So is it not enough the trachea get opened up while you 16 times per day per minute?
So there is that. So the dead space should. Yes. Sir?
What is dead space volume?
So the volume of air that is left behind at the end of to complete end inspiration and end expiration
So that is necessary. That is why we want always the trachea to be kept
should be
open.
left open.
So Cockay's test, if you can do it gently, it can only give you a way that whether this patient will go for a or need in the post-operative period. Yeah,
Yes,
I
sir.
mean,
Yes, sir.
your lower part.
Why
of the
is that you want to know whether patient has tracheomalacia or not? Why is that you want to know? What is the practical importance of that?
So in the post-operative period, if the patient might not be able to be, we might not be able to extubate the patient. The patient might need an eventual tracheostomy.
Okay, fine. Yeah.
Lower
Sir,
border was not palpable, no?
So on deglutition, it was palpable, sir. On only on deglutition.
Yeah, deglutition.
Ramaswamy sir, you wanted to have some questions? Ramaswamy sir?
Good evening. I am Dr.
Yes.
Rajavelu.
Good evening, sir.
Yeah, good evening. I joined a little late. Hello, Jailal. How are you?
Fine, Rajavel sir, welcome.
Nalla irukkom. Okay, fine.
Good evening, Rajavelu.
I joined a while ago.
Yes, sir. You have joined some time back, sir. Please continue, sir.
Observing. I think I will not interrupt. Please continue. That is the tracheomalacia. By the name, it means it is thinning of the tracheal cartilage. That is what Dr. Jailal was expecting from you.
Yes, sir.
Because the continuous pressure becomes thinned out.
Thinned out.
Okay. During extubation, we have to. If Koch's test, you said it is not to be done or something, but it is a clinical test with which we can come to some idea. We can inform the anesthetist. So while extubating, they will not extubate immediately. They'll give some time. Maybe in the post-operative ward will leave as such. And if it settles down, it is fine. Otherwise, patient might need a tracheostomy later on.
Tracheostomy. Yes, sir.
We'll continue, sir.
I just want to know what is the shape of the swelling.
So the shape was irregular, sir. The shape was not regular, sir. It was not. It was more like globular. It was not butterfly in shapes. I was not able to get that.
My idea is whether it is a single lobe or both the lobes are involved.
Both lobes were involved, sir.
You have not mentioned anything like that because you are
So,
saying the.
So I've mentioned, sir. So I've not said mentioned.
She has mentioned bilobar. She has mentioned, sir, in the slides, bilobar disease. And whenever it is asked, we expect you to commit that butterfly shape. Don't mention for a pathological goiter. Butterfly shape is for a normal thyroid shape.
Yes.
Okay, what is described in the books. Once it becomes pathological, it will not maintain that butterfly shape. It becomes abnormal. So don't present the case as a butterfly shape swelling in front of the neck. That is for a normal thyroid. Okay, what's your diagnosis?
So the diagnosis is multinodular goiter. Clinically euthyroid.
Then how do you explain her gain in the weight? You never mentioned in the general physical examination that she is obese.
So yes, I mentioned the BMI.
History. What is the BMI?
The BMI was high, so it was 30.
So a patient with obesity and a goiter, you want to add something at this point of time?
So
okay, has she got any clinical evidence of hypothyroidism? Any points did you find out? Did you put your efforts to find out whether she has evidence of hypothyroidism?
No, so she had no other features suggestive. In history also, she had no, her sleep was intact. She didn't, appetite was intact, no change in bowel, no change in menstrual status.
No, in your general physical examination, all the points you have mentioned for thyrotoxicosis. I am interested to know because there is a history of weight gain and patient has got a more BMI. I am interested in clinical examination to know has she got any evidence of hypothyroidism. What are those points did you look for in the examination for hypothyroidism?
Yes. So for the face, there was no puffy face. There was a loss of lateral eyebrows. For the pulse also there was no bradycardia. The skin was there was no dryness of the skin, excessive dryness of the skin. For the there was no feature suggestive of pretibial, sir, anything.
Pretibial?
No, sir, not pretibial edema. So the reflexes,
examine
reflex. Yes.
Huh?
Yes, sir.
Reflexes.
So
yeah. What
reflexes were normal, sir.
What
So,
reflex
deep
did you check?
ankle reflex, sir.
What
So I
is
checked
that you checked?
deep tendon reflex, sir.
What is that did you do? How did you do, and what is that you are looked for?
So I'm looking for any decrease if there is slowing of the reflex, or if the reflex is decreased.
Slow relaxation of ankle reflex
Yes,
is
sir.
one of clinical sign of hypothyroidism.
Yes, sir.
Okay, so now in this diagnosis, it is a multinodular goiter in euthyroid status.
Yes, sir.
With obesity, you want to put the diagnosis?
So with obesity, I can put, sir.
With obesity, you want to put.
Do you find out whether this patient has any metabolic syndrome?
No, so she doesn't have BP is also with a normal range. So, her sugar she has previously tested. I don't have the report, but she said that it was within normal range. She does have family histories of diabetes. Apart from the weight gain, so she does not have anything else. And she says that she has been slowly, steadily.
Waist hip ratio.
So waist to hip ratio, I did not check. Sir.
No, you are not looking at metabolic syndrome. Sir is typically asking for a hypothyroidism. What is the relationship of the metabolic syndrome and hypothyroidism?
Some metabolic syndrome can be seen in hypothyroidism. It is part of that complex. So if there is
what is subclinical hypothyroidism?
So if the TSH is decreased, but there is a normal thyroid hormones.
It's a postgraduate has to answer. We are not asking a decrease or increase. What is the value of the subclinical hypothyroidism? Or when you will say the value of the TSH above which is a clinical hypothyroidism?
So 0.5 to 5 or international units as the normal. If it is if there is a decrease, if there is less than 0.5, if the TSH is decreased, but the T3 and the FT3 and FT4 are within normal range, then we can consider it as a subclinical hypothyroidism.
So 5, okay.
If it is 0.5 and below, do you call it hypothyroidism?
So that is,
or it is the other way?
That's the hyperthyroidism. So if it is more than 5,
I was asking about hypo.
So if it is hypo, then if the TSH is more than 5.
Now you tell that.
Yes.
More than 5 too? I'm asking very specifically when you look at subclinical hypothyroidism and what is a clinical hypothyroidism? 5
so
to 10. 5 to 10 is a subclinical.
Yes.
International. Then otherwise, above 10 only when we are saying for the clinical hypothyroidism. So what other conditions? So you will get hypothyroidism with the patient with the goiter. And relatively this age group patient, 50 years old.
So any autoimmune thyroiditis can be there, Hashimoto's thyroiditis.
Why do you get
Sorry, sir?
Why do you get hypothyroidism and Hashimoto's thyroiditis?
So because there are antibodies that are directed against the thyroglobulin or thyroid peroxidase, which decreases.
The antibodies will be there in the Graves' disease also.
So in Graves' disease is towards the receptor. So that will that will cause stimulation of the follicles to stimulate the thyroid hormones. But in Hashimoto's,
it's not an absolute, this will be always there. It's only the more amount of thyroid stimulating hormone you are getting there and less of peroxidase. In a thyroiditis, you get more of peroxidase.
Yes.
Antibodies is not the cause for the decrease in the hypothyroidism. What is the mechanism by which it is?
There is.
Tell the pathology of Hashimoto's, then you will answer this.
So there is because it's an autoimmune disease. So the
Graves' disease is also autoimmune disease. Graves' disease will not go to the hypothyroidism.
What happens in Hashimoto's thyroiditis?
This is called triphasic disease.
Initially, yes, sir. Initially there is a period of hyperthyroidism because of stimulation of the.
It is not stimulation.
It is excessive.
What will be the radioiodine uptake value in thyroiditis?
So initially it will be high. So after that it will be normal.
Initially also it will be low. That is how you will be differentiate transient hyperthyroidism from the regular hyperthyroidism. Radioiodine uptake will be high in Graves. It will be very low or net.
No,
Because
no.
here the thyroid follicles are rupturing. It is being restricted by the thyroiditis. So the large amount of thyroxine is released into the circulation. Whatever is being stored will be released. So immediately you will get. So the follicles are not repaired. The follicles will be not there to produce the thyroxine after that. It is a damage. We see, I mean, anatomically there is a damage happening to the follicles. That is why
Yes.
we are not able to get in that. They are entering into the stage of hypothyroidism. Because you must be very cautious in transient hyperthyroidism. Now almost 20% of the hyperthyroidism values, cases we are getting is a transient hyperthyroidism. Patient will come with a T3, T4 high. If you are not
Yes.
able to differentiate it from regular Graves and this, we will be landing up in a further catastrophic effect of putting the anti-thyroid drug on there. Okay.
Yes, sir.
No, you must note this very clearly because for it can either be a hyperthyroid or a euthyroid or a hypothyroid. All depends on which stage you see the disease. So it should be one of the differential diagnosis for everything. And initially there will be more of inflammatory process, and later on it becomes fibrosed everywhere.
Yes, sir.
So that's why you get hypothyroid. Okay, so only the histopathological report will give you the clue. Okay.
Yes.
Good. Then how you are going to proceed, ma?
So I will start with I'll do a thyroid profile, sir, of the patient to see the TSH and FP3 and FP4, followed by an ultrasound of the neck and including the ultrasound of the neck, sir. And based on that, I will proceed, sir. If there is any after that, I will go for an ultrasound guide or image guided FNAC of the lesions.
What is thyroid?
So it is thyroid imaging, reporting and data systems.
What are the characteristic features we look into that?
So we'll see 5 components. We'll see the composition, the echogenicity, the echogenic foci, the margins of the lesion, and the shape of the lesions. Based on that, we will divide it into 5 categories.
What are the characteristics of the malignancy if you are when you are seeing that?
So in the composition, if there is echogenic foci, if the lesion is taller than wide, if
I
the
don't understand. It is echogenic. Is hyperechogenic or hypoechogenic?
so if it is hypoechogenic, that is more dangerous.
Okay.
Then apart from that, if there is any classifications, or if there is any if the lesion is taller than wide, that those are all suggestive of malignancy.
What calcification?
So speckled microcalcifications, speckled calcifications.
Speckled calcification.
So it's microcalcifications.
What is samoma bodies?
So samoma bodies are seen in papillary thyroid carcinoma, but it is a non-specific. Sorry, sir.
What is
Many conditions. So it is a condensed calcified nuclear remnant.
What calcification? Dystrophic calcification, heterotrophic calcification?
So dystrophic calcifications.
So you have done a thyroid scan and you will be able to find out.
Yes, sir. So if there is any suspicious lesions, I'll go ahead for an ultrasound guided FNAC. Fine needle aspiration.
Using which needle? No?
So we use the smaller the better, so the 24 to 25 gauge needle.
25 gauge?
24. So 24.
So what normally this 24 gauge needle is used?
So for the giving the tubercular syringe.
That means you are not working in the ward.
The small needles.
24 gauge needle, where do you use it? Whether you are using it or not?
Suppose we can give it for sensitivity. I don't know. So I don't know. Sir.
Go back to your ward and ask the staff to give you a 24 gauge needle, and you will find out and what purpose you are going to use that.
Right and left, it is being used.
Suppose
every day you will be ward will be used.
Suppose sensitivities.
To ask this question because I'm seeing that students coming and even postgraduate, very good students, when these questions are asked, they are what we are really intended when a candidate is asked for examination, whether you have worked in the ward. It is not a theoretical examination. So if you are really done in the work in the ward, if you have done an FNAC, if you are actively doing, that will be reflected in the small routine procedures which you are doing. And now you know examination as a ward round also. That will be only practical points which will be looking onto that. Okay. So you have done an FNAC and which comes as a follicular neoplasm.
Yes, sir.
So how will you proceed?
Any other, John, any other investigations other than USG and FNAC and thyroid function test for this patient with a big goiter?
So if it is, since it is a big goiter, I can go for a CT scan also, sir.
CT scan. It's mobile, no moving with the deglutition, no malignancy suspected. Simple investigation for anesthesia point of view.
So that I'll go for an X-ray lateral neck, sir, and indirect laryngoscopy.
Only lateral or
X-ray,
AP
lateral,
also
and
you would like?
So AP and lateral of the X-ray for and indirect.
What is the idea? What is the idea? What is the idea of having a AP view?
So for the AP view, we want to see if there's any tracheal deviation. And
why it is important? Why it is important?
So for the anesthetist also, it is
for intubation. You would like to know
for
which direction the trachea is deviated. Trachea is deviated.
Yes.
So that they can plan their intubation. Okay. Okay. On X-ray, what are the calcifications you can come across?
So we can go. We can see macro and micro calcifications.
What are the types of calcifications you can see in a thyroid swelling in plain X-ray of the neck?
Other than microcalcification.
So we can see. So clustered. We can see clustered calcifications, speckled calcifications.
Almost all are like speckled, clustered, micro. Yeah, micro together, more number is clustered. Anything other than that? Eggshell calcification, bigger eggshell calcification, indicating it is a nodular goiter. Okay. On X-ray, if there are eggshell calcification, during sonography, you should insist upon for the sonologist to find out is there any break in that eggshell and parenchyma coming out of that. That is also one of the sign of malignancy, even if it is a eggshell calcification. Otherwise, we take eggshell calcification as a benign disease entity. But on sonography, if there is a break in the eggshell and the parenchyma is coming out of that on ultrasound, indicates that probably it is a malignant nodule and you need to have a FNAC of that particular nodule. That is the importance of correlating X-ray neck and sonography of the thyroid. Okay. So yes. You think now FNAC you have done, it has come as a nodular goiter and patient is euthyroid. So what is that you would like to do for this lady?
So it depends on.
Before you mention the procedure, because you said in the investigation CT neck also you mentioned. I don't know, for every case you will not be mentioning CT neck for a thyroid swelling. So do you know what are the indications where CT is a must? CT is a must.
So if we are suspecting any retrosonal extension, if it's a very large, we are suspecting malignancy.
All malignancies?
So if in large swelling, sir, there's a large swelling, then we'll go for CT because we can't see
what particular malignancies of the thyroid CT is a must. If it is a small nodule and FNAC is papillary carcinoma thyroid, we don't ask for CT neck. We don't ask for. So are there any particular indications for doing CT neck in a case of CA thyroid?
So
when you are expecting local extension,
yes, sir.
When you are expecting local invasion,
yes, sir.
Not only anaplastic,
yes, sir. Any
anaplastic is the indication, but if it is a local invasion is more common in anaplastic, but that doesn't mean that it doesn't happen in papillary. So local invasion if you are expecting, okay, and if you are expecting a multiple nodal disease, extensive nodal disease.
Yes, sir.
To find out nodal disease. Is there any role for MRI in CA thyroid?
So there is no role. So only if there is some. So there is no role. So we don't usually do unless there is some allergic to the. If the patient cannot tolerate the diet.
No. They are all political words. They're all. yeah, if he's allergic, I'll do something. No, there are definite indications for CT, definite indications for MRI in case of CA thyroid. Okay.
Yes,
If it is a soft tissue invasion, you are like a prevertebral invasion.
yes,
If your suspect is common compared to anterior extension, so then MRI will help us to know where exactly in the prevertebral area tumor is extending. If it is
yes,
an organ invasion, like in the form of esophagus and a nodal disease, CT will be the preferred investigation. It's all right. In this case, these things may not be relevant because you said CT, you need to know these indications. So what is the treatment you will be planning for this lady?
Use CT to locate, ma? Which node identification is CT is more useful?
level 6, sir. 7, 6, and 7.
Even a good ultrasonography may miss the central neck node. So it is an isoechogenic nodes. If it is there, the CT will be there. Definitely. Will you use a contrast CT or a non-contrast CT?
So ideally we should use a contrast CT only. But then yes, sir, contrast CT only.
Is it, what is the advantage and disadvantage of using contrast CT?
So, so if you're doing a contrast CT, so the problem with doing a contrast CT is if we are planning for any other iodine studies in the future. So then the contrast we'll have to wait for 2 weeks. So that we have to take into consideration while doing the CT.
More than that, it's normally non-contrast CT ideally, unless it is very specifically indicated, extranodal extension, infiltration into the other soft tissue.
Yes.
So otherwise, you will not go for a contrast CT.
Okay.
And nowadays, there are non-iodinated contrasts are available. Non-iodinated contrasts are available. So if you really want to have a CT done in thyroid malignancies, which should not come in the way of further evaluation and treatment. It is mentioned in the books that you should at least minimum you should wait for 6 to 8 weeks, ideally 6 months. Sometimes iodine can stay in the body for 1 year. That's what the textbooks mention. So 2 weeks is not a sufficient period. So that will delay your evaluation and treatment by doing this. Okay. That is why if you really need, then only you should go for CT scan. Otherwise, it comes in the way of your further treatment of the case.
Yes.
Okay, fine. So what you will be doing for this lady?
What will be your FNAC finding here?
Sorry, sir?
What was your FNAC finding, or what will be your FNAC?
So the patient had come for first visit, sir. The FNAC is not yet done, sir.
So from where you take? You take from the nodule, or you take from the internodular area, solid area, cystic area?
We'll take from the nodules only, sir. We'll take from the largest nodule. If there is any other suspicious nodules, we'll take from that also. You don't have to take only one. We can take multiple FNACs.
Is it the center of the nodule or periphery of the nodule?
What is the minimum FNAC?
You have gone to the radiologist sonography room with the patient to get the FNAC done anytime? You have gone with your junior PG and yourself?
So I've seen FNAC, but not for the thyroid.
No. Did you go accompany the patient and got the FNAC done for your consultant?
So
did you go with the patient?
Yes, I have seen not in thyroid, in breast.
Sir was asking, no, do you do in the internodular tissue or a nodule? You should pick up that. So periphery of the nodule, nearer to the internodular area. That's where you will have the parenchyma. If you put the needle in the center of the nodule, you will get only necrotic tissue. Necrotic tissue. Okay.
Okay. What is your plan?
Okay. FNAC is nodular goiter and sonography says nodules involving only the thyroid and there are no lymph nodes found, and biochemically she is euthyroid. So what will be your line of treatment?
So the patient in this case, the patient has asked to be operated because of cosmetic reasons, sir. So I'll offer her a total thyroid.
Lady, I have given the scenario. I have made it very simple.
Yes, sir.
You need to answer what is the plan. That's all.
The plan is total thyroidectomy, sir.
Dr. John, don't have a prefixed idea and talk. Sir has given a beautiful scenario and go with that. It's always better.
Yes, sir.
Yeah. Okay. Why why do you plan for a total thyroidectomy in this lady? Anyway, 23 years, she is all right. Leave her alone for another 20 years. Why do you want to operate now?
So because this was, so the size of the swelling, so the
Your
size
plan
has,
of surgical treatment.
sorry, sir?
Substantiate your plan of surgical treatment.
So I'll go for a total thyroidectomy, sir.
Why do you want
Because-
to go for thyroidectomy or invent surgery at all?
So in this case, we don't have to go for a surgery if the patient is clinically euthyroid and has no symptoms. But
Don't take a stand like that. On one end to other end, don't take a deviate. Now you have already said total thyroidectomy. Now you need to justify. Always you can justify your stand.
yes, sir. So I'm going for a total thyroidectomy because the patient has asked for a cosmetic purpose. So there is no point of doing an incomplete procedure. Also, sir, the
patient asks, you will not do.
For a moment, you forget the cosmetic.
So the patient also has multinodular goiter, sir. So the chances of it regressing is the pathology is not going to regress, sir. So I'll go for a total thyroidectomy. Also. So there's also a chance of the patient going into some hypothyroidism in the future also. So for that also I will go, or the patient to develop any toxic symptoms in the future.
Only that?
They will.
Patient will develop toxicity, secondary thyrotoxicosis, other complication.
Sorry, sir?
You are expecting only hyperthyroidism to develop, not any other complication in this case.
No, so they can also be with long-standing goiter. They can also be trichomalacia. The patient might have.
She is reluctant to mention thyroid cancer now, Jailal sir.
Yes, except that she's talking everything.
She's reluctant now to mention thyroid develop. Yeah, why reluctancy now? You should come out with now. Yeah, long-standing malignancy in a nodular goiter can result in malignancy. What malignancy she may develop? What malignancy she may develop?
So she may develop follicular carcinoma, sir, but she can also have papillary carcinoma.
No, you should not mention all what is existing on earth.
Follicular
carcinoma.
carcinoma.
In MNC.
So follicular carcinoma.
If it is papillary, from where it comes? Your nodules will produce follicular, or
yes, sir.
where papillary comes from where?
So that can be I don't know, sir.
In between nodules.
So now you are decided, now you are planned for this total thyroidectomy.
Yes, sir.
You are not interested in doing a subtotal or Dunhill's?
No, sir.
Why?
So because there's always a chance of recurrence, and if then the patient has come specifically for cosmetic reason, then reoperating on the patient will be very hard because of the altered anatomy. So I'll go for a total thyroidectomy, sir.
Kanagavel, sir?
Yes, sir.
Sir, because we have one more case of
No, sir.
next only.
I think the seniors here, actually, AIMS Rishikesh faculty, Professor Huda sir and Professor Som Prakash are with us. And we have Kanna sir. They can give their comments, and if they have any questions, then we move to the next case.
Yes.
Som Prakash sir?
It was a very good discussion, and I think Jen should also follow what the questions have been asked.
Yes, sir.
And yeah, very important, because these are the questions, standard questions which are asked in the exam, right? And
yes.
You need to do a bit more of background reading, and everything which has been said has to be gone back and looked at the book and then finalized. They make it a learning, knowledge base. Okay.
Yes, sir.
Thank you.
Thank you, sir. Professor Farhanul Huda sir, are you with us, sir?
Yeah.
Yes,
It was a very nice discussion. Thoroughly enjoyed it. Just one thing, the candidates should not go with a preset notion of a particular diagnosis. Yes. They should always go with an open mind, and they should discuss the case logically. That's very important, rather than just sticking to one particular diagnosis.
Yes, sir.
I think that should be the take-home message from this discussion.
Yes, sir.
Thank you.
Thank you very much, sir. Professor Kanna sir? I think Kanna sir is not with us. Ajay Kanna sir? Jane, do you have any questions? Because we have been asked questions by the national faculty. Normally, we allow definitely students to clarify if you have any doubts or any contentious thing which you have read. You want to have any clarification with the senior faculty here?
No, sir. No, sir. Thank you, sir.
Thank you very much, Jane. Good luck to
Thank
you.
you, sir.
It
Thank
is
you.
only to position yourself with the amount of knowledge the examiner can take you beyond the case discussion. So get back to that, note down all the questions. This recording is available. Please replay it, find out the areas where you are lacking and update you with the fresh knowledge. That is all is needed, right? It is not
Yeah.
to pull you down or anything. So the way you understand, the way the exams can go, then your knowledge should be driven to that level. That is the message.
Yes.
Thank you very much, Dr. Jain, for joining. And I thank Som Prakash sir and Farhanul sir. I would request both of you to stay with us for the second case and you can contribute yourself because I could see both of you keeping quiet all through. The next case is from Vellore Medical College, Dr. Suri Narayanan. It's a case of neck swelling. Jane, you also can stay with us.
Yes, sir. Thank you.
Kindly contributed by Professor Rajavelu sir. Suri Narayanan, please switch on your video, start your PowerPoint. We are
May I
ready to
audible,
see
sir?
your slides, Kana. Yes, ma. Good. Make it full screen now. Introduce yourself, your unit chief, head of the department, and start your presentation.
Is it full screen, sir?
Still not it, ma.
Not yet.
Okay, sir.
Don't worry,
Shall I
Kana.
start
We are
presenting?
unable to make it full screen. Yeah, now it is perfect, Kana. You are okay.
Good evening. I am Dr. Surya Narayan from Vellore Medical College. I am here to present a case of neck swelling. I am under the guidance of my HOD, Dr. Raju sir, and my unit chief, Dr. Loknathan sir, and Dr. Gauri Shankar sir. Chief complaints: 47-year female, hailing from Vellore, daily laborer by occupation, belonging to a low socioeconomic status, presented with complaints of swelling in the right lateral aspect of neck for the past 2 years. History of presenting illness: she was apparently normal 2 years back. She developed a swelling in the right lateral aspect of neck, which was insidious in onset for a duration of 2 years, which was initially small in size, approximately 1 centimeter, gradually increased to attain the present size of approximately 5 centimeter. There was history of a rapid increase in size for the last 3 months. It was not associated with any pain. There was no history of any ulcer or growth in the oral cavity. There was no history of excessive salivation or difficulty in speech, difficulty in chewing or pain during chewing or initiation of swallowing. There is no hair litosis. There is no history of loosening of tooth. There is no history of any voice change, difficulty in breathing or noisy breathing, difficulty in swallowing or pain during swallowing, nasal stuffiness or nasal discharge, ear pain, loss of weight and loss of appetite. There is no history of any hypo or hypothyroid features, no history of cough with expectoration or hemoptysis, no history of evening rise in temperature, no history of any other swelling in the neck or elsewhere in the body, no history of fever with chills or night sweats, lethargy, generalized weakness, no history of any syncopal attacks, no history of trauma, no history of drooping of eyelid or decreased sweating of face, no history of abdominal pain, jaundice and altered bowel habits, no history of headache and seizures. Past history: not a known case of diabetic, hypertension, asthma, epilepsy. No history of tuberculosis in the past. No history of any contact with tuberculosis in the past. No history of any drug intake. No history of any recent surgery or no history of irradiation in the past. Personal history: consumes mixed diet, normal bowel and bladder habits, no consumption of alcohol, non-smoker, no use of any arecanut, palm muscle or snuff dipping, no history of any substance abuse. Family history: no history of any head and neck, thyroid, breast, abdominal malignancies in the family. Menstrual history: attained menopause 2 years back. Obstetric history: P1L1A0, full term normal vaginal delivery. Summary of my history: a 47 female presented with swelling in the right side of neck for the past 2 years, with rapid increase in size for the past 3 months, with no other history suggestive of malignancy, tuberculosis, no significant past personal or family history.
Yeah, what do you provisionally think?
Sir, the swelling is in the right lateral aspect of neck in the anterior triangle. The most common swelling is the metastatic lymph node. The patient is non-smoker, not doesn't have any risk factors, so it may be an occult primary secondary metastasis, sir. There is no history of any tuberculosis.
Hang on. Sorry. You can't
Yes,
just
sir.
jump to that it could be occult. What are the types of secondaries in the neck? First of all, anyone over 50 years of age with neck into swelling in the neck, you take as secondaries until proved otherwise. Now,
Yes,
what
sir.
are the types of secondaries? You just can't say that it's an unknown primary. How can you say that?
Okay, sir.
How do you classify primaries in the secondaries in the neck? You have a primary and you have a secondary, known primary with secondaries in the neck. You have secondaries in the neck, but clinically you cannot detect the primary. That is called cup.
Okay, sir.
That's cup. And
the
the third is,
and
if we can't detect it clinically also with secondaries in the neck. So you just can't jump to that. You just say that they're probably secondaries. A known primary, you cannot say as yet now. You've not done the examination also.
Yes, sir. So I cannot comment about the location yes, sir. I'll proceed with the clinical examination and comment about the swelling, sir.
No, you are thinking in terms of secondary malignancy, first of all, possibility. But you
Yes,
said
sir.
the swelling for 2 years, it was normal. Suddenly, the secondary swelling going for a rapid increase in size. What is the mechanism of that?
Why do you think the secondary has increased and the primary has not? Any reason for it?
There may be sudden
Are there some tumors which grow slowly, but the secondaries go very fast?
Yes, sir.
Or the primary can disappear, the secondaries persistent.
Okay, sir.
Right? Okay, so there are many reasons. Let's go back to your history before we start off. Because
okay, sir.
What are the common causes of secondaries in the neck? Sources.
Sir, the most common source is the oral cavity malignancy in nasopharynx and hypopharynx. In a female, the thyroid malignancy can also cause neck secondaries.
It depends on the level of the lymph node.
Yes, sir.
Upper half and lower half.
Yes, sir. If it is in the upper half, it is most likely to be oral cavity malignancy. If it is in lower half, the jugular lymph nodes, it may be in the tongue, nasopharynx, oropharynx, hypopharynx. Aerodigested. Okay, sir.
Right, and the lower?
In the lower tracts. Yes, sir.
Suran, yeah, for the same reason, when you start presenting the case, rather than just mentioning lateral side of the neck, you should elicit the history. Did she notice upper part of the lateral side, mid part of the lateral side, or lower part of the lateral side? If you can find out from the history and present exactly like that, then you can localize your possibilities. Patient can understand whether it is in the upper part of the lateral side of the neck or lower part of the lateral side of the neck. She will understand if you put the questions. So okay, if she come out the answer that she has noticed a swelling in the upper part of the lateral side of the neck, then you can limit your what sir is asking, you can limit your answers. You got the point.
Okay, sir.
So in this case, has she noticed in the upper part or the lower part?
Upper part, sir.
Yeah, so see, you should highlight that point in the history.
Right.
You should highlight that point in the history.
Okay,
so
sir.
what are the causes of say lower part of
you
the
got
neck
the point.
Secondaries?
Yeah, if she has come with the history of lower part of the neck, eliciting dysphagia or eliciting epistaxis, eliciting change of voice, probably will not have any meaning at all if it is in the lower part of the neck. Okay, so
yes, sir.
In this case, it is upper part of the neck. So you should concentrate on finding out symptomatology pertaining to upper aerodigestive tract, which constitutes 3 parts. What are those 3 parts? Upper aerodigestive tract,
nasopharynx, oropharynx, hypopharynx.
Nasopharynx, oropharynx, and
hypopharynx.
Hypopharynx or laryngopharynx. So these are the 3 areas you should concentrate on. Okay.
So what do you think are the most
on the pain in the ear?
Sir, pain in the ear, if yes, sir, if there is a primary within the in the tongue or base of tongue or in the oral cavity, it may refer to cause a refer to pain in the ear, sir.
Your case history, I am not saying that you are not entering into that,
Or,
asking the referred
Yeah,
or
I think we should go back to his history because the history is incomplete. Sorry, I'm not very satisfied with it. Let's go back to your history, please. Can we go back to your history?
sir, I'm in the history. Sir.
Okay. Okay, what do you think are the common sites for malignancy in the upper half of the neck? Second is in the upper half of the neck and the lower half of the neck. You have to take
Sir,
history accordingly.
yes, in the upper half of the neck, it may be a
We
tongue
discussed this,
malignancy.
aerodigestive. Okay, fine.
Yes, sir, aerodigestive tract. Lower half of the leg, it may be from the GI malignancies can present in the
No,
layer.
be more
Tongue
specific.
malignancies.
Go according to the percentage. You just can't say
Okay,
GI malignancy. GI is right from esophagus down to the anus.
Okay, sir. Yeah, most common is stomach malignancy is carcinoma of the stomach.
No,
Or the big.
no. Carcinoma of stomach is very rare. It is breast, lung, kidney, and melanoma.
Okay, sir.
This is the percentage according to frequency. Breast, lung, kidney, and melanoma. Okay.
Okay,
So
sir.
you have to take history for that. She's a lady. You have to take history of breast very carefully. This patient.
Okay, sir.
Please, sir.
Especially when you are presenting suspecting a secondary nodes, you must be little more focused, and you have to decide whether it is upper air or digestive. Then your question should be more focused on that. You should look for epistaxis, bleeding from the nose. You should look for the pain in the eye. There are so many other factors we can bring in. The history itself we should bring out, and at the summary when you are saying, it should be something that you are mentioning, not just very vaguely saying that there is a lateral swelling and it is rapidly increasing. So all this allow time you are allowed to ask so much of question and come to a conclusion. Not you are asking so much of question, not without a purpose. So that you should conclude in a very positive way. What you are thinking, it should be there.
Okay, sir.
Little more focused and wide thought on the questions you must be including.
Okay, sir.
Next slide, please. Okay. Okay, next slide. Okay.
Till we are very much on the evening rise of temperature. I'm not. What is the purpose? Tuberculosis.
To ask for the history of tuberculosis.
What is the evening rise of temperature? When?
Sir, later in the
Huh?
later in
Maybe
the day, sir.
ask any question on that. Evening rise of temperature or anything else you see in a tuberculosis fever?
Don't know, sir.
Don't just mention that you read and what is that, what type of fever you get in tuberculosis, when do you get the fever more, and what is that evening that is mentioned in the Western literature.
Okay, sir.
Surya, otherwise I would stress on lymphoma rather than tuberculosis here. So 50-year-old lady with a lung for 2 years and suddenly increasing, I'll think of lymphoma rather than tuberculosis, right?
Okay, sir.
Where you can also have evening, night temperature, night sweats or evening rise. Right. Okay, next slide, please. Okay. So basically, you're ruling out most of the. What does she work as? Does she have
Daily
any
laborer, sir. No, sir.
any exposure to chemicals, to wood?
No, sir.
Wood. Look, nasopharyngeal carcinomas. You have to ask for all that.
Okay, sir.
Which is missing in your history, right?
Okay, sir.
So can we go on, sir?
Go ahead.
Okay, sir. General examination after obtaining proper consent and adequate exposure in the presence of female attendant. The patient is conscious oriented, afebrile, pallor is present, no icterus cyanosis, generalized lymphedema or clubbing. Skin, hair, palms and nails are normal. ECOG status of 1. She is moderately built and reduced. BMI of 22. Her vitals are BPS 120/80 measured in right upper arm in sitting position. Pulse rate is 78 per minute. Regular rhythm, volume and character. Temperature is 98.4 degree Fahrenheit. This is the image of the patient. Local regional inspection. A solitary oval swelling in the right anterior triangle of the neck of size 6x4 centimeters with smooth surface, extending superiorly 2 centimeters from the angle of mandible, inferiorly 6 centimeters from the clavicle, medially 6 centimeters from midline, laterally 2 centimeters beyond the right sternocleidomastoid. Skin over the swelling is normal except for a skin fold present along the inferior border. Swelling remains same on contraction of deep fascia. It is non-pulsatile, no other visible swellings. Trachea appears to be in midline, no scar, sinus, or engorged veins over the swelling. Palpation, there is no local recent temperature, tenderness is present. A solitary oval swelling in the right anterior triangle of neck, level 2 and 3, of size 6x4 centimeters. It is extending superiorly 2 centimeters from angle of mandible, inferiorly 8 centimeters from the clavicle, medially 6 centimeters from the midline, laterally 3 centimeters beyond the sternocleidomastoid, which is hard in consistency, which is mobile in both horizontal and vertical directions, with restricted mobility on contraction of sternocleidomastoid, which is non-pulsatile. Skin over swelling is pinchable, and there is no proximal cough. Examination as solitary swelling of size 1x1 centimeter, palpable in the front of the neck, which extends from 1 centimeter from midline, laterally 2 centimeter from sternocleidomastoid, superiorly 2 centimeter below the upper border of thyroid cartilage, inferiorly 6 centimeter from the clavicle. It has well-defined borders, firm in consistency, which moves upwards with deglutition. Is non-mobile. Does not move with protrusion of tongue. Skin over the swelling is normal. Rest of the gland is not palpable. No other palpable swellings. Trachea is midline. Bilateral carotids are palpable. Percussion, dull note over the swelling and resonant note over the mandible. Auscultation, no bruit heard over the swelling. No carotid bruit heard. Other system examination, skin over scalp, posterior neck and shoulders are normal. Mouth opening normal. Lips, gums, buccal mucosa, palate, retromolar trigon, tongue, floor of mouth is normal. Tonsil, posterior pharyngeal wall is normal. External auditory canal is normal. Nasal cavity, parotid, eye examinations are normal. There are no eye signs. Breast examination, bilateral breast are normal. There were no palpable lymph nodes, palpable mass. Systemic examination, lymph nodes. There are no palpable lymph nodes in the left cervical and bilateral supra, infraclavicular, axillary, and inguinal regions. Musculoskeletal system, no bony irregularities, rib, spine, skull, and no spine tenderness. No muscle weakness is present. CVS, S1, S2 heard, no murmurs. RS, bilateral normal muscular blood sounds, equal in all areas, no added sounds. For abdomen, soft, no palpable mass, no argulomegaly. Digital rectal examination, normal, no mass palpable. CNS examination, no focal neurological deficit. Reflexes are normal, cranial nerves are normal. Summary of my case, a 47 female came with complaints of swelling in the right side of neck for the past 2 years with rapid increase in size for 3 months with no other history suggestive of malignancy, tuberculosis or hyperthyroidism, no history of compressing symptoms or significant personal or family history. With a solitary swelling in the right anterior triangle of the neck, level 2 and 3 of size 6x4 centimeter, which is nodular surface, hard in consistency with the restriction of mobility on contraction of sternocleidomastoid with a positive platysma sign associated with a solitary thyroid nodule in the left lobe of 1x1 centimeter, which is firm in consistency with well-defined borders. No other lymphadenopathy and other system examinations were normal. My provisional diagnosis is locally advanced right cervical nodal metastatic nodal enlargement, probably of thyroid origin, in a euthyroid state without complications.
The nodule in the thyroid is on the left side, no? Nodule is on the left side.
Surya,
Please unmute yourself, Surya. Surya, please unmute yourself, ma.
Surya Narayan, please unmute. Yes, sir.
Yes, sir.
Yes, sir. Yes, sir. He is there.
No, sir, I didn't do it, sir. Sorry, sir.
yes, Surya Narayan.
Yes, sir.
In the history, we said that you should ask upper part of the neck or the middle or lower, and you said in the history that she has noticed in the upper part. But looking at the clinical photographs, it looks like it is exactly in the middle of the neck, lateral side. You got the point?
Yes, sir.
Yeah, so if you would have said that she has noticed in the middle part of the neck, probably you would have discussed at history level that possibility of a thyroid cancer without looking into the patient, and you would have diagnosed diagnose the case. You got the point?
Yes, sir.
So that is the importance of knowing where exactly is the swelling in the lateral side of the neck. Okay, so clinical photograph says that probably it is in the middle of the neck, middle of the lateral side of the neck. Okay. In the presentation, you have mentioned that it is in the anterior triangle of the neck. You have presented as an anterior triangle neck swelling. It is underneath sternocleidomastoid. Is it not, your presentation?
Yes, sir. It is in the anterior triangle, which extends towards the posterior triangle also, sir.
What is the plane of the swelling? Lateral neck swelling in this case?
So the plane of the swelling is deep to the fascia, but it is also involving the sternocleidomastoid also, sir.
Deep to or underneath sternocleidomastoid. You have done the test, no? By making the muscle taut, the swelling becomes less prominent and less mobile. I think you have presented that.
Yes, sir.
Okay. And in the presentation, you have mentioned for a thyroid nodule, that percussion, it has got a dull note. And there is no dull note on the over the sternum. That's what you have presented in the slide. So did you percuss over the thyroid nodule for the dull note?
He has percussed the lymph node.
Lymph node and
he has mentioned that dull note over the nodule. You have mentioned in the slide. You come back. Previous slide. Okay. Anyway, you are not supposed to, dull note over swelling. I don't think you should do this for a neck swelling. Okay.
Okay, sir.
Okay. So you are not supposed to do it. Okay. And Jailal sir was mentioning, no, I think there is a mix-up of that palpable thyroid nodule. Is it on the right side or the left side?
It is in the left side, sir.
Should we take out? Huh?
It is in the left side. Thyroid nodule is in the left side.
Yes, sir. Thyroid nodule is on the left lobe?
Yes, sir.
Okay. Is it a possibility that there can be a thyroid nodule on the left side and the person can have a metastatic deposit on the right neck nodes? Is it possible or not possible?
It is possible, sir.
It is possible. It is possible. Okay, fine.
How does that happen? How does that happen? How do you explain?
Yes, sir.
N or M?
Sir, in a case of thyroid, there are rich internodal lymphatics are present, and the tumor may be multifocal.
That's fine. That's fine. Okay.
What you are feeling may not be the actual. Maybe another microfoci may be
yes,
there.
Sir.
Okay, Surya, is your swelling on the neck compressible? Is the cuff a pulse? Is it? You said it's non-pulsatile. Is it a single node? Are there multiple nodes? Are they matted? Are they matted? Right.
It is a single. Yes, sir.
Right. I mean, all those things have to come out clearly. Also, examination of the abdomen has to be done more carefully. I must mention about liver specifically, not say abdomen, no free fluid, per rectal examination. All this thing has to come up. The breast, the axilla, right? Because this is not a very straightforward case which you're doing. I know it's difficult, but that's it, right?
Okay, sir.
You are still thinking because of there is a 1 centimeter nodule you are able to make out in the thyroid. You are thinking in terms of secondary. Can you think of a swelling in the anterior border, almost in the upper border? The swelling is there for 2 years. Suddenly it is increasing in size. It's almost, you said clinically you said it is a smooth swelling, but palpation you said little nodular. There is no obvious any other change there.
So the patient doesn't have any risk factors. So the risk factors are oral malignancy and suspect.
Other than your secondaries, other than your thyroid, can you think of any other possibility?
Yes, sir. It can be a lymphoma. The other differential diagnosis of lymphoma, neurofibroma, paraganglioma, and sarcoma, sir.
See, our question is here. It was there for 2 years. Suddenly, the node is getting enlarged in size. Can it be other than node? Anything else can be there in the anterior border of the sternocleidomastoid?
Branchial cyst.
Can it turn malignant?
Is it cystic?
No, sir, it is not cystic.
It will not turn malignant?
I don't know, sir.
Okay. It can turn malignant.
Okay, sir.
Now you will think in terms of this. What is the provisional diagnosis now? You said it is a T4A.
It is a T1N3B, sir.
Suryanarayan.
Yes, sir.
Yeah, I want your one honest answer for this question.
Okay, sir.
Is it that after examining this lateral side neck swelling, you examine the neck nicely and you could pick up a thyroid nodule? Or is it that you got a FNAC done for that lateral swelling and got a papillary carcinoma deposits, and then you went back and examined for the thyroid and you could pick up the thyroid nodule in this case?
Sir, in this case, first I
You want-
examined the lateral swelling in the oral cavity in the OPD, sir. Then the patient was in the ward. When I was taking the history, then I examined the thyroid region. I couldn't find, sir. After reports, then I specifically looked for the thyroid nodule. Then only I could find the nodule, sir.
So you could examine the thyroid and pick up the nodule only after the FNAC report of the lateral neck swelling. Am I right?
Yes, sir.
Huh?
Yes, sir.
Okay, fine. Thank you. In other words, as a postgraduate, what is that lesson you learned from this?
Examination must be much more detailed.
In the sense, whenever you have a case of middle neck, that is level 3 nodes, which is suggestive of deposits, your examination is incomplete unless you have looked for thyroid nodules.
Yes, sir.
Okay, so we need to examine the thyroid nicely and look for thyroid nodules, because that is the commonest site for level 3 neck isolated level 3 neck deposits, isolated, like this case.
Yes.
Suryanarayan, are you following TNM staging or your own staging? I do not know what is that N3B in thyroid. What is that N3B?
So it is the N3B is for the lateral neck metastasis.
You are preparing a case and presenting. Please be careful.
Yes, sir. Yes,
There
sir.
is no N3 in a thyroid carcinoma in a TNM staging.
Yes, sir.
HSCC.
அது எக்ஸ்ட்ரா நோடல் இன்வேஷன் ரீசன்ட் கிளாசிபிகேஷன்ல போட்டிருக்காங்க.
N1A and N1B.
Yes, sir.
இல்ல N3ல கூட N3B வந்து எக்ஸ்ட்ரா நோடல் கிளாசிபிகேஷன் irrespective of the size போட்டிருக்காங்க.
No, there's no thyroid lab. You don't bring that, sir. N3. We have only all the groups.
It's a nodal இதுல இருக்கு.
ENE, extranodal extensions they call ENE.
Yes.
That will be there, but HSCC classification with the T1, 4A, 4B outcome, but not
Yes, sir.
N1.
Yes, sir.
N0, N1. There's no N3B, so you can. So it is a relatively rare. If it is going to be, it is lateral thyroid without that, then it's rare. Okay, we'll go ahead with that. With that clinical finding, we'll go ahead. And how you are going to proceed?
Sir, initially I will do the FNAC of the, will proceed with the ultrasound of the neck first, and as an extent of my clinical examination to look for the swelling. Then I will proceed with the FNAC, and depending upon the FNAC report, I will proceed further. Sir.
You will ultrasound of the swelling only, or ultrasound of this node
Ultrasound
also?
of the neck. Yes, sir. Ultrasound of the swelling, ultrasound of the neck in details.
What is the purpose of doing ultrasound on this nodal swelling?
Sir, if first I have to confirm whether it is a nodal swelling or it is any other swelling. Then I have to look for the detailed enlargement of the thyroid and the vascularity also, sir.
I can't tell you whether this could be a malignant node.
Yes, sir.
What are the features?
This well, the malignant node, it is round, it is hypoechoic, it may have it shows microcalcifications, and there may be increased vascularity, sir.
Hypoechoic?
Hypoechoic, it's a loss of fatty hilum, and there may be
Please be careful on that. Hypoechoic, we are talking about thyroid. When you have a cyst or a nodule, we are talking about, then we are going for a hypoechoic as a significant factor. But when you are looking for the node, what you are going to look
okay,
for?
sir. Sir, the node the shape becomes round, there is loss of fatty hilum, there may be microcalcifications, and there may be increased vascularity, sir.
What is halo?
Central halo, sir. The central halo is lost.
So you have done an ultrasound and it turned out to be a node. Then how you are going to proceed?
I will do a fine needle aspiration cytology, and depending upon this fine needle aspiration cytology, I will proceed further, sir.
So will you do thyroid uptake scan here?
No, sir.
Why not?
After FNAC, if it comes as an thyroid, papillary carcinoma thyroid or thyroid tissue, then I will do a baseline TSH. If the TSH is normal, yeah, TSH is normal, then I will proceed with the further investigations. If the TSH,
Other than
only if there is,
papillary,
sir,
other than papillary carcinoma, any carcinoma can produce a node.
in thyroid, sir.
Thyroid.
Yes, yes.
Age
Yes,
of
sir.
the lady is around 47 years.
Medullary carcinoma thyroid, anaplastic carcinoma, sir.
Not medullary carcinoma. We are talking about thyroid. Means I'm not talking about parafollicular cells.
Even anaplastic carcinoma of thyroid, follicular carcinoma of thyroid can also can present, sir, in 20% of
Even
cases.
what I am asking is, have you had that Hurthle cell tumor carcinoma?
Yes, sir. Yes, sir. Yes, sir.
What are the features of Hurthle cell carcinoma?
Hurdle cell has it is a variant of a follicular carcinoma there where there will be Hurdle cells or Ashkenazi cells which is present.
Again,
They
be
are
careful. Go and update yourself. The WHO classification has come. Now Hurthle cell is not a part of follicular. It is a separate entity.
okay, sir.
Like what we are talking about papillary carcinoma, follicular carcinoma, and Hurthle cell carcinoma is given as separate entity. And there is a borderline carcinoma is included. That all will be going to the pathological when you are saying. So Hurthle cell carcinoma when you are thinking, and what are the possibilities you get here?
In
Do
my
you get
case, it will
any
be
Hurthle cell carcinoma?
yes, sir. Nodal metastasis is present.
So what is the role of uptake scan in Hurthle cell carcinoma?
Hurdle cell carcinoma, they are not only 38% of Hurdle cell carcinoma are radioiodine away, sir.
So what scan you have to do? And which
For
scan will you present?
Hurdle cell cancer, sir. Sir, I couldn't get the question, sir.
If you are doing a which scan, the Hurthle cell carcinoma will produce a hot nodule.
Technetium 99.
So what will be your, suppose you are doing uptake scan, what will be your finding in the node? It will be hot or cold?
Cold nodules.
Hmm?
If it is a technetium 99, it will be hot nodules.
You are doing uptake scan of iodine. So what will be the feature in the node?
Cold.
Cold.
No, sir.
Please understand the cold and hot is in relation to the nearby structure. Here
Okay,
you are
sir.
saying cold because in a malignancy, the neighboring thyroid will take much more than the nodule. But when you are comparing it on the local on the sternocleidomastoid, the node will take more iodine than the sternocleidomastoid, and there it will be always hot. So
Okay,
secondaries
sir.
of the thyroid, the uptake scan will not be a cold nodule. It will be always a hot nodule. Because always the hot and cold is in comparison to the surrounding uptake, you are going to say that.
Okay.
Sir, Jailal sir,
Yeah.
is it that they should use this terminology of cold nodule or hot nodule only in relation with the thyroid, not in relation with the secondary deposits?
Absolutely, sir. If you are saying that in
Yeah.
the secondaries, it will be hot. Secondary nodule, it will be hot. It is not cold.
So it
Because
is in relation with only thyroid scan, not for the secondary deposits. It is only
not
for the thyroid scan. You should use this
hot and
terminology.
cold is only with the surrounding what is there. With the thyroid, which is uptake is more or not, that we are saying. So think in terms of, because there is a node is there, where more you have to put in as a carcinoma. So in this
Okay.
case, and what is the stage of the patient?
Stage 1. Stage 1.
Stage 1. So what are the carcinomas you know which has only 2 stages?
Only thyroid malignancies.
All thyroid malignancies?
Only differentiated thyroid malignancies.
Follicular carcinoma is also a differentiated thyroid malignancy. All age group?
No, sir. Only less than 55.
Okay. That is What are the carcinomas has 3 stages? Can you say there is a carcinoma which has only 3 stages? Testicular carcinoma.
Okay, sir.
Is there any stage whereas carcinoma has 5 stages?
Neuroblastoma.
Okay, very good. So how will you proceed on this case? Will you do any triple assessment or triple assessment in thyroid?
Yes, sir. I'll do ultrasound and FNAC. FNAC, and since this is a case of locally advanced malignancy, so I'll add a contraception CT scans.
No, CT, I'm not asking whether you are doing a quadruple assessment means you are doing genetic or molecular biology.
Yes, sir. Genetic or molecular biology we can do, sir. Where facilities are available.
So what you are
In a case of
expecting?
papillary carcinoma thyroid, I look for the mutational studies. There is red unco mutation, PTC1 or PTC3, and BRAF mutation in a case of papillary carcinoma thyroid. If it is PTC3, it is poor prognosis, and a BRAF mutation, it is a poor prognosis, sir. It is aggressive tumors. And I can add a
Dedifferentiated carcinoma?
dedifferentiated carcinoma is the papillary carcinoma turns it into an anaplastic carcinoma. That is known as dedifferentiation. So, if papillary is to turn into a dedifferentiation, the mutation is P53 and P16 mutation. The differentiated cells turns into an undifferentiated cells.
What is insular carcinoma?
Insular carcinoma is a aggressive variant of papillary carcinoma thyroid, sir. It is occurs in a younger age. The size is very large and the prognosis is very poor, sir.
It's not an aggressive variant. It is a poorly differentiated.
It is a dedifferentiated variant of a papillary
carcinoma.
Yes, sir.
What are the aggressive variants of the papillary carcinoma?
Tall cell variant, columnar variant, hobenile variant, diffuse sclerosis variants.
Now the solid variant is also come under the papillary carcinoma.
Yes, sir.
Previously,
Solid variant.
type anaplastic carcinoma. Now the solid variant is also coming in the papillary carcinoma.
Okay, sir.
You have the report of this patient, FNAC report of thyroid nodule and the neck swelling.
Yes, sir. FNAC report came as papillary carcinoma thyroid metastasis. FNAC is the neck swelling.
Deposits.
Yes, sir.
FNAC of the neck swelling, thyroid nodule.
Thyroid nodule, they didn't do FNAC, sir. While FNAC of neck swelling came as papillary carcinoma thyroid.
Okay. So what will you do next? Is there any role for tumor markers here?
Yes, sir. Tumor markers, preoperative tumor marker is not of much of a role, sir. Postoperative tumor markers can use.
What is the tumor marker you will ask for?
Thyroglobulins.
Thyroglobulins. Okay. So what is your plan now? You would like to prove that it is from the thyroid?
Since FNAC came as papillary carcinoma thyroid, it is from the thyroid.
No. Because there are palpable nodules, you don't want to prove that the nodules are the primary.
No, sir. Anyway, my treatment is going to be total thyroidectomy, sir.
What prevents you to prove by simple FNAC of the thyroid nodule? It's not required.
I'm having a diagnosis of papillary carcinoma, so
even then, I think since you have picked up a nodule and sonography has shown nodules, I think you should not mention that it is not required, proving the primary site. Okay, otherwise, you will not be proving where exactly is the primary. Okay. So you need to have a FNAC of the thyroid nodule. Without FNAC of the thyroid nodule, even though you said that the treatment remains the same, that is why you don't want to prove that the primary. You need to prove.
Documentation.
FNAC of thyroid nodule.
Okay, sir.
Okay. After that, what is your plan now?
Immediately, you need to look into that, because what we are going to classify any thyroid tumor on the grade of that, whether it is a AJCS classification, AMS classification, or MCCS classification, all there, the grade of the tumor is important. Where
yes, sir,
here you will be able to get to know what is the type and if it is what is the variety of it is going to happen. So you said,
okay,
earlier you said anaplastic carcinoma will also produce a node.
Yes, sir.
So it is mandatorily required for you to know what is your thyroid tumor there. So you must do a FNAC here, and then only you will be able to proceed.
Okay, sir.
What is the idea of doing a CT in this case?
So since it is a locally advanced cancer, the CT, I will do a CT to look for the invasion and to look for lateral cervical lymph node metastasis and the central group of lymph nodes also, sir.
Any other notes? Central, anyway, all this you will be tackling during surgery. What all you
Mediastinal
have
group of
mentioned now?
nodes.
Huh?
Mediastinal group of lymph nodes.
Exactly. The CT, the role of CT, important role in a deposit case where there are deposits in the node, in the lateral side of the neck, lateral deposits, mediastinal nodal disease,
Okay,
which
sir.
cannot be clinically examined. That is
Yes,
more
sir.
important than what is the percentage of this lady having the mediastinal lymphadenopathy on CT?
I don't
Once
know.
there are lateral deposits, what is the percentage? Almost 30% of these people will have a mediastinal nodal disease.
Okay, sir.
Once there are lateral neck nodes.
Okay, sir.
Okay. Yeah.
So
So what will you do?
Sir?
You are repeatedly using the term locally advanced carcinoma. Is there a term called locally advanced thyroid carcinoma? That is only we are using for the breast. Here
Okay,
you
sir.
said it is stage 1 carcinoma. So don't use that locally advanced. All that terminology is not there in the thyroid.
Okay, sir. It is high risk disease.
You can put it as a high
No,
risk.
no. Why you want all those adjectives? Why not to have a simple, it's carcinoma thyroid with secondaries in the neck?
Yes,
Because you don't want to use these simple words.
no, sir.
And once your diagnosis is thyroid, you need not mention the physiological status of the patient, like what we insist for a benign thyroid disease.
Okay, sir.
Thyroid cancer is a specific diagnosis where physiological status, it goes without saying that the patient is in euthyroid status. Why? Why this is so? Can a toxic goiter develop malignancy?
No, sir.
No, absolutely
Never.
no.
It is not absolute, sir. It is the chance of malignancy is less than 5%.
Percentage of toxic? Less
than 5%.
Less than 5%. Okay, less than 5%. And you have mentioned without complications. So what is that complications you want to highlight in this diagnosis? What is that?
So without any, there is no local infiltration or nerve involvement.
This terminology we use for inguinal hernia diagnosis. Okay.
Okay, sir.
Yeah, without complication in the form of obstruction, strangulation, like that. So make it simple. Make it simple. Okay. It is like a simple case where you have felt nodules and you have diagnosed that it is a secondary in the neck. So it is carcinoma thyroid with deposits in level 2 neck nodes on right side.
Okay, sir.
Is it okay for you, or you are not accepting our diagnosis?
Okay,
you will accept, no? Okay. How will you proceed now? How will you proceed?
Yes, sir. I will look for the extent of the disease. I will do a CT of a neck to look for local involvement.
Fine. We discussed that. What will you do? What will you do?
Sir, I will do a total. I will proceed for the surgery, sir. I'll do total thyroidectomy with the central compartment neck dissection and.
For the tumor board, or you will directly take a decision? No, will you directly take a decision, or
yes,
you
sir.
will do substitution for the tumor board?
No, sir. I can directly take the patient for surgery.
No, as long as if the examiners are from here, like our medical colleges, it is fine. They would, none of the examiners coming from the big institute will accept that if you say without tumor board, I will take a decision. So it is better you always have a discussion on the tumor board. So there they will be always putting it at risk. Even there is a lot of discussion is taking, because you said your tumor nodule size is less than 1 centimeter. Even without node less than 1 centimeter, definitely you can go for the lobectomy. So that is very standard, less than 1 centimeter, no other features. But here there is always definitely the node is there. So Better if you can say, use the word, we'll have a tumor board discussion and then we'll go for a decision.
Okay, sir.
Go ahead.
Yeah, name the complete procedure, what you are going to plan.
Total thyroidectomy with a central compartment neck dissection with right side modified radical neck dissection, sir.
You substantiate for each one of them.
When a T1
Why
tumor,
total?
you see a T1 tumor, are you justified in doing a central neck node dissection?
For a T1, since it has a lateral cervical node metastasis, the percentage of central compartment involvement is more than 40%. So I will do a central compartment neck dissection as well as the, since only right side is involved, I will do a ipsilateral neck dissection, sir.
Good.
Ipsilateral neck dissection involving 2, 3, 4.
So there's
level 2, level 2,
question here. Surya, there's one question.
Yes, sir.
See, the nodule you felt in the thyroid is on the left side. There is every
Yes,
possibility that there could be a node on the left side also. So it all depends on your CT finding.
Yes, sir.
Suppose you have a node there on the left side, then what will you do?
I'll operate on the left side also.
Okay, now
Only if it is clinically radiological.
You are going to
Sir?
do what is operation or not?
Same sitting?
Same setting, sir. I will do total thyroidectomy and do a lateral leg dissection.
Now, what is the neck dissection? Don't use that. You must be specifically say, Sir has asked, specifically use the word for what surgery you are going to do. Lateral neck dissection, actually, you are still confused, more interested on breast. So, a lot of terminology you are using, which you use for the breast.
No, right side he said the MND, sir. Right side he said modified neck dissection. He said that right side. If there are on imaging, if there are nodes on the left side, what is the neck dissection we'll be doing on the left side?
Left side same modified radical neck dissection.
Modified radical.
No, I would be happy if you use still more further specific word. Modified neck dissection. There is a type 1, type 2, type 3.
Type 3, sir. Functional neck dissection.
No, there is it same? Functional neck dissection and modified neck dissection 3 is same?
Yes, sir.
Oh.
If your plan is to do bilateral MND, which one you will do first, left side or right side?
Right side.
Why?
Right side already there is a nodule mass is there.
First I will. Yes, first I will. First I will tackle. I don't know, sir.
Yeah, what is the importance of this MND? Ultimately, what is that you are going to save? Preserve?
Spinal axis, internal jugular vein and sternocleidomastoids.
Okay. Can they be sacrificed on either side, all three structures? Or there is one structure where it cannot be at any cost, it has to be saved at least on one side?
Internal jugular veins.
Exactly. If it is to be saved on one side, which is, you should make it 100%, 200% sure that you are going to save. So which side you should be operating first?
Right side.
Less affected side or more affected side?
More affected side.
If you injure there and if you do some problem there and you need to ligate that vein, then what is that you will be able to do it on the left side? Where you are supposed to preserve the structures at any cost, you should be doing that side first.
Okay, sir.
It is like exactly like you are doing a total thyroidectomy, you have done a laryngoscopy and one side is paralyzed, vocal cord is paralyzed. So which side you will start dissecting first to mobilize the lobe?
Contralateral side.
Contralateral, where it is functional.
Yes,
at
sir.
any cost, you have to preserve that. You got the point?
Yes, sir.
So where you need to save, do it first. See that it is saved.
Okay, sir.
Okay, fine. Why you are insisting that we should be doing a central neck dissection separately? You are mentioning that point in this case.
Sir, the central neck lymph nodes will be involved, sir. There is a high chance of central neck.
When you say functional neck node dissection, it includes central neck node dissection also. So you are removing that. The difference in modified type 3 and functional, modified type 3, even level 1 you will remove. You will preserve the three structures, but you will remove the level 1 node. in a functional neck node dissection, which is only specific for thyroid carcinoma, we will not remove the level 1 node. So here, if you are using modified radical, that means you are using 1 to 5 nodes you are going to remove. So here it is very specific nodes. So ideal word you should always use is a functional neck node dissection. Though by virtue of preserving the 3 structures, it is a type of modified, but we don't remove all the node. Second, squamous cell carcinoma, when you are doing, you have to remove everything in continuity. As a flap, you are writing totally. Here, the dissection mode itself is little different, but you can use the same technique. But that's why we are using the functional neck node dissection for the thyroid carcinoma.
When do you use specifically this central node neck dissection in thyroid cancers? When do you use this term?
What is that indication and when do you use?
Yeah, specifically you should highlight this point.
In the case of medullary carcinoma thyroid,
exactly, with the N0 neck, clinically N0 neck. If your diagnosis is medullary carcinoma thyroid with clinically N0 neck, your answer should be total thyroidectomy with central neck node dissection. In all other well-differentiated cancers, if the neck is N0, you have to answer only total thyroidectomy. If the neck is N1, unilateral or bilateral, depending on the findings, you need to highlight functional neck dissection. You need not highlight about central neck node dissection in other well-differentiated cancers. You understood, Surya?
Yes, sir. Yes, sir.
Only point which there is a difference, which NCCN is very particular, and most of the agreeing on that terminology. When there is N0, no prophylactic neck dissection.
No dissection. Yes,
only
sir.
that American Thyroid Association will insist if there is a T3, T4 lesion, if there is a primary T3, T4, you have to do a prophylactic central neck node dissection even when there is N0. So you can, as we mostly follow the NCCN guidelines, you can say that is definitely when there is N0, we will not do a neck node dissection. The central neck node dissection is not an easy job. That is end up in, unless we are doing it very carefully, we will end up in damage.
I think he should tell us, sir, because he repeatedly is mentioning central neck node. What are the greatest problems of doing central neck node dissection whenever your plan is to do total thyroidectomy with central neck dissection? What are the greatest disadvantages? These patients are more prone for what?
More prone for nerve injuries and parathyroid
Exactly. The incidence is almost doubles and triples when your plan is to do central neck dissection. Okay, both parathyroid or hypocalcemia and the recurrent laryngeal nerve, it doubles.
Yes, sir.
Okay, it's very high, very high.
Do you like it the inferior thyroid? How do you like it the superior thyroid?
Sir, I would like it inferior thyroid.
No, inferior thyroid, where do you like it?
Capsular branches.
Superior?
Capsular branches.
So you have done a surgery, it is perfect. And
okay, sir.
You see the parathyroid is still in your specimen.
Okay, sir. If it is confirmed that it is a parathyroid, I'll auto transplant it into the ipsilateral sternocleidomastoid.
What do you want to use? Sternocleidomastoid you want to use or the forearm you want to use?
Sternocleidomastoid, sir.
Why? Why not in forearm?
Sir, forearm only in the case of men 2A, I will inject in the forearm. Otherwise, in rest of I can inject the sternocleidomastoid, sir.
Any reason for this? Your answer is right. Any reasoning for this? What is that men 2A? What is that? What is that? What is that specifically you took into now?
So men 2A, the parathyroids are more prone for adenomas. So I will inject.
In other words, you are talking about hyperparathyroidism.
Yes, sir.
In other words, you are talking about a pathological gland.
Yes, sir.
And what sir's question was for a physiological gland, where the gland was normal, but accidentally it was removed. So what is the difference between a physiological gland being removed and a pathological gland being removed?
I didn't get the question, sir.
You have removed a pathological gland in hyperparathyroidism.
Okay, sir.
More so if it is a parathyroid hypertrophy, that is all 4 gland involvement or a 4 gland disease. And you have removed 3.5 or all 4 of them, and you want to keep. And if by chance, if there is a recurrence, if it is kept in the 4R, it is easy to investigate and tackle.
Yes,
you will not be going again into the neck for re-exploration if there is a recurrence. And there are chances of recurrence in a 4-gland disease in hyperparathyroidism. So easier to explore in the 4R, brachioradialis. In a physiological gland, where accidentally 1 gland has been removed or 2 glands have been removed, and you have got a nearby structure there, and there is no question of recurrence of hyperparathyroidism because functionally they are normal. So you are already exposed and you need to keep them there itself. How do you keep? You are removed, you just keep it like this, or do you do something else?
No,
before you keep?
Yes, sir. I will trim down into many tiny pieces and inject into standard glomerulocytes.
What is the reason?
Sir, if we did it into tiny pieces, then the vascularity can be better, sir.
Not vascularity, it is a viability. It gets nutrition better. It doesn't have a blood supply, named blood supply there. It will survive, it will be viable by diffusion. It gets a nutrition. So chances of viability is high by making slices.
Slices, yes, sir.
Okay. How do you prevent this hypoparathyroidism or removal of parathyroid glands while doing these surgeries?
Sir, first I look for the parathyroid, and I ligate the inferior thyroid artery as close to the gland as possible. I ligate the capsular branches, and yes, sir.
Which parathyroid position or more?
Sir, if the parathyroid, I will look for the superior parathyroids are superior to the artery, and the inferior superior to the nerve, and the inferior parathyroids are inferior.
What is that? Superior parathyroid is superior to what?
Recurrent laryngeal nerve.
Oh, okay. You are giving in relation with recurrent laryngeal nerve.
Yes, sir.
Okay.
Yeah, identify it and preserve it, sir.
Along with that, you need to mention few points. Ultimately, what is that we are asking is, how do you identify these parathyroids on table? What are the landmarks on table? On table landmarks we are asking.
They are brown. They are brown round in color. The location is located in the lateral aspect of thyroid, and in relation with the, I will look in the relation with the nerve and the artery, and avoid a dissection in the arteria.
There are certain parathyroid is in a very constant position. You can easily go to that. Certain thyroid, inferior thyroid will not be in the certain position. So how do you identify where it is superior parathyroid? Any landmarks you have?
Okay. Name some thyroid conditions for which you have planned for surgical treatment where there are very high chances of patient developing hypoparathyroidism after surgery.
One is locally advanced malignancy, anaplastic carcinoma, Graves' disease.
Again, you are using that locally advanced. No, Jailal sir said we are not discussing CA breast. We are discussing thyroid cancer.
Locally infiltrated
Forget about that local business. You just mentioned the procedure where there are very high chances that person may develop hypoparathyroidism.
In the case of malignancy, in case of Graves' disease, in a recurrent case.
Okay. Any other?
Previously irradiated.
Previously, we may not do surgery in thyroid in previously irradiated, no?
Yes, sir.
Okay. Yeah, accepted. One is, where there are deposits in the neck and you are doing neck dissection along with total thyroidectomy. Second, surgery for thyrotoxic goiter.
Yes, sir.
Toxic goiter, you are doing a surgery. More so for diffuse goiter, if your plan is to do diffuse goiter. Third, when it's a recurrent re-exploration, you have done half surgery in the beginning and then you got a surprise report and you have planned for re-entering into the neck and doing revision total thyroidectomy, very high incidence. Fourth one, which we discussed in the beginning, if your plan is to do central neck dissection along with total thyroidectomy, very high chances of inducing hypoparathyroidism.
Okay, sir.
Okay. So there, and in such scenario, we should be careful when we plan our surgeries.
We have to finish within 10 minutes. Kanagwal sir is sending it.
Yeah, he has sent a message.
Yes.
Done a surgery, perfect. No nerve injury, no parathyroid injury. How we are going to follow it?
Sir, I will follow the patient after 4 to 6 weeks with a radioiodine scan, uptake scan, and I will give radioiodine ablation.
You will not put any replacement or suppressor dose you will be putting for the patient?
No, sir.
Okay. The post,
I
immediate
will
post-operative, you will not give any L-traxin? Okay.
no, sir.
Okay.
I will not give any thyroid. After 6 to 4 weeks, I will do a baseline thyroglobulin value and anti-TGA levels, and I'll do a radioiodine uptake scan, and depending, I'll ablate the gland with radioiodine ablation, and follow up the patient with the
That
after.
the point of research you should get to do the radio uptake scan.
Sir?
Do you really want to do a uptake scan in this case?
Yes, sir.
Or you will go for a radio ablation?
Sir, I will do radio ablation, but I will do before radio ablation. This is high risk disease, so I will do a uptake scan and proceed with ablations to look for to find out the baseline value whether it is
There's no
a.
time. Please, Srinarayan, there's no time. You go back and read. There are certain conditions
Okay, sir.
where you are very sure you need to do a radio ablation. A tumor more than 4 centimeters, extra nodal
Yes, sir.
thyroid is there.
Extra
Nodal
lateral circum.
then there is not even necessary to go and do a ablative scan. I mean, uptake scan. You can straight away take up the case
Right
for
away.
the ablation you can do, but not you can do. So this tennis, thyroglobulin elevated, node negative.
Uh,
The thyroglobulin level,
structurally
what is
by
normal level?
so less than 1.
So when
Non-detectable,
suppose
sir.
it comes as a 10 picogram, but you are doing uptake scan, there is no node is not taking up.
So it is a then it is a biochemically incomplete response. So I will do a
Now
FD
as per the statistic, nearly 20% of the case can come like
FDG
that.
PET. FDG PET, sir.
FDG PET you take. So what does it indicate? If the FDG PET is taken and FDG PET is not taken, whether if the PET is not taken, will you give a radioiodine uptake for still that?
Yes, sir.
What is the reason for this? Why there is a
Sir, see, if there is no structural evidence disease and raising thyroglobulin, we should even if the PET shows does not show any lesion, we should give ablation dose of radioiodine, sir.
So not taking up the reason again, this is the differentiation. That part is
Yes.
not taking up the tumor. You are taking.
If histopathology is comes as medullary carcinoma thyroid, will you follow the same protocol what you mentioned just now?
Sir, I will do a baseline CE and calcitonin values, and I will do a total therapy with the central component dissection and
No. You have done surgery,
Okay,
done
sir.
neck dissection, and histopathology comes as it is medullary carcinoma with deposits in the neck. So post-op follow-up, what you mentioned just now, will you follow the same protocol?
Sir, the post-operative I will follow much earlier, sir. The follow-up of the patient will be much
No,
earlier.
I-131 ablation, what you mentioned just now, will you
No,
follow
sir.
the same protocol
No,
for
sir.
if
No,
the
sir.
pathology is medullary carcinoma thyroid?
No, sir. No, sir.
Why?
It is not radioiodine awake.
It doesn't have?
It doesn't. It is not radioiodine awake, sir.
Yeah. It is not a bit. Okay, fine.
So if you are still saying the node is there, somewhere still the mass is there, it is not responding to radioiodine ablation, what is the possibilities you will go with?
Sir, if it is not responding to radioablation, I can try on another dose, or if it is viscerally invasive, I will go for a external beam radiotherapy, IMRT. Sir. If I do a genetic testing, and depending upon the genetic testing, I can also give, if it is an unresectable tumor or a recurrent tumor, which is unresectable or metastatic, I will give. I can add chemotherapy.
What is the maximum dose of I-131 ablation which can be given in a single sitting?
300 microcuries.
300 is a very huge volume. Sir, 160?
Yeah.
160. Upper limit of the maximum dosage uptake. What sir was asking Surya, like in the beginning, first uptake scan followed by ablation. Nowadays, what is followed is the straightway ablative dose is given.
Okay,
straightway ablative dose. But the idea of doing an uptake scan in the beginning is to calculate the total dose required. If you really want to know the total dose required for ablation, do a uptake scan, calculate the dose, and then give the required dose.
Okay,
Or
sir.
straightway you give, and then 60 curie they calculate and give it a ablative dose.
Usually
When is
that
the next follow-up scan is done after giving the first ablative dose?
6 to 8 weeks after, sir.
again,
8 weeks.
all thyroid, please answer depending upon the grading. If it is a mild risk, no risk, there is no
Okay,
need to follow up. You can
If it is
wait
not,
for
yes, sir.
if there is a high risk, you need to follow up immediately. So, safer side on you to say, but any question. So, first of all, I will grade that carcinoma, whether it is a mild, moderate, severe. Then, depending upon that, what is the dose of replacement dose of thyroxine or a suppressive dose of thyroxine you keep?
2 to 3 times higher. It is 300.
Again, it depends upon your type of carcinoma. If it is a mild
Yes, sir.
carcinoma, your intention is keep even up to the
In a
0.5
mild,
level,
yes, sir.
you can keep.
In a
If
low
it's
risk case, I
severe,
will keep as,
so again,
yes, sir.
all these treatments and modality of surveillance depends upon the either whatever the formula you are using, AGES or MCAs, whatever you are using, and
Yes, sir.
come to a conclusion whether it is a mild, moderate, severe, and then go ahead further.
Yeah. In a mild case, I will keep it as less than 0.5. In a high risk case, 0.1. If the tumor is more, yes, there is no residual tumor or no thyroid is negative for years, I can go up to 2, sir.
What the targeted therapy you use?
Targeted therapy, there may be ethanol injection, radio frequency ablation, high frequency ultrasound waves.
Targeted therapy is
Right.
not that. That is locally ablative therapy. Targeted therapy is a monoclonal antibodies you are going to use.
Monoclonal, yes, sir. Monoclonal antibodies, the drug of choice is larotrectinib, and if it is resistant, cabozantinib, and if the tumor mutational burden is more than 10, I will use pembrolizumab. NTRK mutation is there, I will use selpercatinib, and if kinase inhibitors, if it is BRAF positive, I will give kinase inhibitors, vandatinib, vemurafenib, and sorafenib.
What is pembrolizumab?
Kanagavel, sir.
Yes, sir. Yes, sir.
So we are done with this, or you would like to?
Yes, sir. I think we should allow the student to ask any questions or doubts if he has. And we have other faculty also being with us. Dr. Somprakash Basu, sir. And we have Khanna, sir. Your quick comment, sir, before we move on.
Yeah, it's a good discussion. I have one small question for you, Surya.
Yes, sir.
Why there is iodine ablation is done? I mean, the patient takes the iodine orally and then iodine ablation is done. Why don't you go for tele radiation in the neck?
Sir, it is a more targeted therapy, sir. The tumor cells take up the iodine, and it is more targeted, and the surrounding structures are less involved. It is only 5 millimeters of surrounding structure involved. And if you give external beam radiotherapy, surrounding structures are unnecessarily involved.
Oh, in the present day, the IMRT therapy, it is very easily targeted. But what is the reason why they take it orally?
It is in radioiodine. It also take up useful for distant metastasis also, sir.
Do you have any idea how much radiation dose is given by the radioiodine?
In a case of remnant, it is 30 to 50. It is in a residual, it is 50 to 100.
No, what in terms of gray or centigrade, how much radiation do they receive actually?
In external beam radiotherapy, it is a centigrade. It is
I am talking of iodine, radioiodine.
Iodine is 100 to 300 microcuries, sir.
No, I am talking about how much radiation dose that's in terms of gray or rats.
I don't know, sir.
No, it goes up to a level of 15,000. Okay.
Okay, sir.
So you cannot give that by the teleradiation. It is going to burn the whole neck.
Okay, sir.
Understand? All the structures, the soft tissue and all, everything.
Okay, sir.
So that's the reason why, because as you said, it selectively uptake is there. So these are localized in those areas where the thyroid cells are. And rest of the tissue is spared. That's why they can tolerate so much of radiation there.
Okay, sir.
Okay.
Khanna, sir. Khanna, sir is not available. Do you have any doubts, Surena?
Sir, only regarding neck dissection, sir. Sir, if in a thyroid, if yes, sir, if you should mention MRND, then level 1, level 2 lymph nodes should be cleared. In thyroid, level 1, level 1A, 1B is not required, sir, and also 5. So, what should I say, sir? For this, sir?
Two ways to do that. Either you must use the word functional neck node dissection. Otherwise, the safer side is use the word comprehensive neck node dissection. When all
Comprehensive.
the
Okay, sir.
are using the word comprehensive neck node dissection, then instead of going for the type level, see, modified 1, 2, 3 is only to say the how much that the structure you are going to preserve. The node clarity for the radical and modified almost is the same. There is no change. So here thyroid, you are not going to remove the first. So you are not. It is justified to say modified neck node dissection. Either you must use the word functional neck node dissection or you must use the word comprehensive neck node dissection.
Okay, sir. Thank you, sir.
Any other faculty comments we have? So there are, sir, Guru Shantapa sir, can we call a close? Jailal sir, any other
Yes.
points, sir?
Yes, sir.
So we have Karnakaran sir, Rajiv Sahai sir. Anybody want to add a comment, sir?
No, sir. Thank you.
Ajuvelu sir. Rajavelu sir.
Rajavelu sir.
Rajiv sir, you.
No, fine. I'm fine.
Yeah. Thank you very much. I think with the permission of the faculty, we'll call it a close. I thank all the students who have been with us today in the YouTube and to the Zoom. Probably the next week, we will be having something on oral cancer. Been some time we discuss oral cancers or any other skin and subcutaneous cancers. Any department, any postgraduate who can contribute. Sorry, sir.
One discussion on the all the that small short cases. You must even small even.
How many we can have, sir? Because this we have 2 cases per 2 hours. Maybe we can have 4 cases, sir. Will that be okay, sir?
4 cases
Sir,
will be
it's
good.
4 is too much, sir. 4
Too
is
much.
too much.
3 guys.
No, sir. No. Half an hour, sir. Half an hour each. Not to exceed the time, sir. Short cases like that, sir. Maybe.
Let it be only 2 cases only, but whether it is short or not, only 2 cases, so that they can have more discussion.
We can take a detailed discussion. Okay,
even if it is a hydrocele or hernia, it can have a little more discussion.
Sir. Perfect, sir. Perfect. I get your point, sir. Okay, sir. We'll plan, sir. Next week, I'm unsure, but subsequent week, we can definitely take that, sir. Short cases. Thank you very much, sir.
Thank
you, everyone. Thank you,
night,
Dr. Jain and Dr. Surya. I thank both Rajavelu sir and Somprakash sir for kindly contributing with the permission